the original single non-like cell technology for detection and treatment of leukemia, a well-known paradigm of diagnostics and
I'm so sorry for interrupting, Dr. Alexander. Still, your slide is not. Yes. Can we share the PPT on your behalf? You shall just present.
Сейчас.
No, yes. We will share the screen, Doctor, on your behalf. Because we can see only half of the slides. So keep it in slideshow mode. You will find the option at the bottom of your PT.
Кто-то может, да? Ну, давай. What is it?
Yes, that is an option at the bottom where you can put slideshow.
Опция влияния. Поделиться, если я... Вот это вот параметр. Сейчас. Униживать для выбора нескольких ока. Так. Пауза. Лицо управления слайдами. Конференция.
Doctor, the slideshow option is left.
I tried. Значит, не видит конференцию. Вот здесь же этот слайд же виден. Чат. Часть. Сейчас появится. Ну вот, допустим.
Doctor, can you hear me? Kindly click on the first icon, which is left to the volume button.
Sorry, it doesn't work. Это что ли? Мне лучше поделиться чем. Сейчас я найду, подожди. Сейчас. Включим. Вот одно только. Вы запустите демонстрацию экрана. Дальше что? Чат. Ага. Да.
Пошли быстро, очень. Слишком быстро.
Подожди. Так вот я не могу это. Понимаешь, это. Ага, есть. Can you see my presentation?
Yes, doctor, we can see your slides.
Ага. Значит, таким образом. Сейчас. Our data. No. Сейчас. Our data. The idea to study DNA and proteins of a single cell appeared when a glass micropipette with its tip sharpened as an injection needle was manufactured. You can see the scheme of obtaining samplings of Palatine tonsil atypical cells. The smears of Palatine tonsil scrapings inspected with a light microscope. Atypical cells are usually bigger than other cells. They are easily revealed. Scraping is better than biopsy or puncture. Scraping is not traumatic. It can be carried out with the least waste of time. It takes a little pecuniary means. It allows to obtain epithelial lymphoid tissue, a few erythrocytes at the same time in health, in tonsillitis, and atypical cells in remote cancer. This is micro photographs of Palatine tonsil cells. In figure 4, you can see epithelium of Palatine tonsil in health. In figure 5, a part of palatine tonsil structure, looking as a lymphoid follicle in lung cancer. You can see epithelium of Palatine tonsil in tonsillitis. In figure 7, you can see atypical Palatine tonsil cells in breast cancer. In figure 8, you can see large mitosis of Palatine tonsil cell in stomach cancer. You can see atypical Palatine tonsil cells in stomach cancer in figure 9. You can see atypical Palatine tonsil cells in remote liposarcoma. In figure 11, atypical Palatine tonsil cells in remote liposarcoma. You can see atypical cell and spherical bodies looking like extracellular vesicles besides the atypical cell. In figure 13, you can see Reed-Stomberg cell in remote lymphoma. You can see atypical epithelial-like containing leukocytes, nose cell of a human Palatine tonsil in chronic lymphocytic leukemia. The puncture and sampling of the contents a nose-like cell cytoplasm in leukocytes. The puncture of the atypical cell's nose cell and sampling of cytoplasm contents leukocytes, the nucleus, and the isolated nucleus. Future steps. The DNA, RNA, and proteins, leukocytes found in cytoplasm of the nerve cell and spherical bodies, besides atypical cells, should be studied with the known single-cell omics technologies. The received structures can be used for making medicine drugs, vaccines, monovalent vaccine, subunit vaccine, gene therapy drugs, and therapeutic monoclonal antibodies to treat leukemia and chronic lymphocytic leukemia in particular. The same approach can be used for designing new drugs for personalized medicine for leukemia and other malignant and non-cancerous diseases. Thank you for your time. Так, сейчас посмотрим. Так, пауза. Да? Управление. Пока. А они меня слышали вообще? Поделиться написано. Нет, ну все нормально, что это. Вот. О.
Everyone a pleasant and productive meeting. I am Dr. Asiye Erdoğan from Turkey. I would like to thank the organizing committee for their invitation as a speaker. In this presentation, I would like to tell you about my study titled The Relationship Between American College of Radiology Thyroid Imaging Reporting and Data System, ACR TIRADS, and Fine Needle Aspiration Cytology in Geriatric Thyroid Pathologies.
I can't screen share.
So can we share the screen on your behalf?
I can't screen share.
Yes, doctor. Can we share it on your behalf?
Okay.
Dr. Asiye, if you are facing a technical issue, can we share the screen on your behalf? You shall just present. Is it okay for you?
Okay.
Okay, we will do it.
Okay.
Okay, and please comment me for moving the slide, like next slide, so that we shall move the slide.
Okay.
Can you able to see the screen?
Yes.
Okay, doctor, please proceed.
Okay. Second slide.
The world population is getting older with each passing year. Thyroid cancer is the most common endocrinological cancer, and its incidence is increasing in all populations. Although the increase in prevalence has been attributed more to the increased use of imaging methods and to the higher sensitivity of ultrasonography by some authorities, there are also studies suggesting a real increase.
And curves.
Any thyroid nodule should include the following criteria on USG. size, echogenicity, cystic areas, micro or macro calcifications, presence of a hypoechoic rim surrounding the nodule, halo, nodule borders, structure, asymmetry, vascularization, high-risk criteria for malignancy on USG, hypoechogenicity, border irregularity, absence of halo, presence of microcalcification, transverse lung configuration and transverse view, increased intranodular vascularity. Fine needle aspiration cytology is considered to be the most important and primary diagnostic tool for the evaluation and diagnosis of thyroid lesions regardless of the age of the patient. It has worldwide application due to its simplicity, safety, and cost-effectiveness. Fine needle aspiration biopsy is the gold standard in the diagnosis of thyroid nodules in the presence of clinical indication. The FNAC result is also a determining factor in determining the surgical strategy. According to the literature, the sensitivity of thyroid FNAB varies between 65% and 99%, and the specificity varies between 72% and 100%. These results of FNAB may be affected by operator efficiency, diagnostic difficulty, and classification of suspicious lesions. It is known that the number of thyroid nodules also increases with age. There is a direct relationship between the age of 65 and over and the malignant potential of thyroid nodules. Survival is known to decrease with age, and it is reported that it decreases to 92% in young adults and 48% in patients over 70 years old. In our study, it was aimed to examine the USG and FNAC results of thyroid nodules in the geriatric age group and to discuss them in the light of the literature. The files of 129 geriatric patients with thyroid nodules were analyzed retrospectively in the Ear, Nose, Throat Clinic of University of Health Sciences Adana City Training and Research Hospital. In our study, the USG characteristics of the patients were categorized by scoring according to the American College of Radiology Thyroid Imaging Reporting and Data System, ACR TIRADS. According to this, in ACR TIRADS scoring, the nodule has internal structure, echogenicity, shape, border features. Accordingly, in terms of malignancy, 7 points and above highly suspicious, 4 to 6 points moderately suspicious, 3 points mildly suspicious, 2 points not suspicious, 0 points are considered benign. FNAC diagnoses were grouped according to the Bethesda classification. According to this, non-diagnostic or unsatisfactory, 2 benign, 3 atypia of undetermined significance or follicular lesion of undetermined significance, 4 follicular neoplasm or suspicious for a follicular neoplasm, 5 suspicious for malignancy, 6 malignant. The risk stratification of the patients according to their ACR TIRADS score and the FNAC results were compared statistically. In our study, there were a total of 129 patients, 34.1%, male and 65.9% female. Although the ages of the patients varied between 65 and 88, the average was 71.19 plus 5.24. Thyroid nodule sizes monitored on USG were a minimum of 1 centimeter and a maximum of 5 centimeters, with an average of 2.60 plus 1.03. 41.09% of the nodules undergoing FNAB were in the right lobe, and 58.91% were in the left lobe. In thyroid function tests of the patients, serum T4 value was found to be minimum 0.4, maximum 2.4, mean 0.84 plus 0.25. TSH values minimum 0, maximum 49, mean 1.98 plus 5.85. There was no statistically significant difference between gender groups in terms of age, tumor size, T4 and TSH variables. According to the ACR TIRADS rating, 4 patients, 3.1%, were benign, 58 patients, 45%, were not suspicious, 38 patients, 29.5%, were mildly suspicious. 25 patients, 19.4%, were moderately suspicious, and 4 patients, 3.1%, were highly suspicious. Among the FNAC diagnostic groups, 27 patients were non-diagnostic diagnostic, 87 patients were benign. 2 patients were suspected of Hürthle cell neoplasia, 10 patients were atypia of uncertain significance, 2 patients were suspected of follicular neoplasia, and 1 patient had malignant cytology. In our study, although USG provided very valuable information in the approach to thyroid nodules, no relationship was found between ACR TIRADS and the geriatric age group and FNAC results. A thyroid nodule is a separate lesion that occurs in the thyroid gland and is radiologically separated from the thyroid parenchyma. The main radiological evaluation of thyroid nodules is always performed by ultrasonography. Considering the prevalence of nodules in the society, deciding which nodule is benign and which nodule is malign is among the most common problems encountered by the radiologist. Thyroid nodules are seen 4 times more in women than men, and its prevalence increases with age and low iodine intake. In our study, it was seen approximately 2 times more in women. Delal et al. Compared the USG features of malignant thyroid nodules in 109 geriatric and 824 non-geriatric patients. And the only difference seen in their study was that malignant nodules of geriatric patients had lower peripheral hypoechoic halo, but this difference was not statistically significant. In the study conducted by Richmond et al., on 314 patients with 404 thyroid nodules in 2020, according to TIRADS, it has been reported that 22% of malignant nodules do not require FNAC in the first encounter, and therefore ACR TIRADS may cause thyroid cancer to be overlooked in the pediatric group. In addition to histopathological differences in the pediatric population, due to a higher rate of cancer, ACR TIRADS was insufficient to predict malignancy. In 2019, Trimboli et al. Reported a significant relationship between EU TIRADS and FNAC results in a 3-center study with 1058 thyroid nodules in 495 patients. EU TIRADS reported that thyroid nodules showed high performance in differentiating malignancy, negative predictive values were high, and the number of unnecessary FNACs significantly decreased. In our study, no relationship was found between TIRADS and FNAC results in the geriatric age group. P equals 0.117, biopsy decision should not be made based solely on USG data. Considering the high probability of malignancy in this age group, a biopsy decision should be made considering the patient's history and clinic. As a result, we think that the approach to thyroid nodules in geriatric patients should be followed up closely not only with USG data, but also with clinical and history-based findings. Thank you for your attention.
The effectiveness of different methods, sinus floor elevation, the lateral approach. In the posterior maxillary area, in order to put an adequate length of the implant, which is 10 millimeter of the length, as well as the 3.5 to 4 millimeter of the diameter of the implant, we need to have a sufficient amount of a bone in the posterior maxillary area. If we don't have a sufficient amount of a bone, we need to do elevation of the sinus floor in order to provide an adequate bone mass. Another method for the implantation of the posterior maxillary area is using a short implant, for example, 4 to 5 millimeter of the short implant. But in this case, it will lead into the unfavorable crown to root ratio and decrease the longevity of the implant process. Another method for augmentation or for the implantation of the posterior maxillary zone is using basal implant. But in case of basal implant, we need to have a edentulous patient in order to provide good stability and longevity of the implant for full arc rehabilitation for implant placement. What are the variations of the sinus lifting technique? This depends upon the height of the bone. If we have the height of the bone, which from the 1 to 4 millimeter from the crest to the floor of the maxillary sinus, it is recommended to do open sinus lift through lateral approach. But if we have the height of the bone from the crest to the floor of the maxillary sinus from 5 to 8 millimeter, in this case, it's recommended to do open or closed sinus lifting with or without implantation. But if the bone height from the crest to the sinus floor is from 8 to 10 millimeter, it's recommended to do closed sinus lifting along with the implant placement. But if the bone height from the crest to the sinus floor is more than 10 millimeter, there is no need for sinus lifting procedure. So what are variations of sinus lifting procedure? The closed sinus lifting, which is also called transcrestal internal sinus lift, and also it's called bone-added osteotome sinus floor elevation. So this technique is first introduced by Summers in 1994 by osteotomy by using an osteotomes as well as mallet and bone graft carrier. So how this procedure is performed? In this procedure is recommended to do if we have at least 4 or 5 millimeter of the initial bone height from the crest to the sinus floor in order to provide adequate primary stability for implant placement at the same time with sinus floor elevation. So in this method, we will use at first the pilot drill in order to prepare implant bed initially, and then it's followed by using an osteotomes. These osteotomes, there are variable osteotomes, including the sharp tip or a flat tip. So we'll start from the sharp tip, from the smallest diameter, which is 2 millimeter of the diameter, and then it proceeds until to the final diameter of the osteotomes in order to perform the breakage of the floor of the sinus and elevation of the sinus floor. And following the multiple usage of the osteotomes, especially if you are going to put multiple implants, it is preferred to do the osteotomies at the same time. After finalization and the lifting of the floor, we have to carry the bone graft and augment in between the sinus floor as well as the sinus membrane. And following the augmentation with the bone graft, we will proceed for implant placement. So this implant also will make a carrier of the sinus floor upward. I have to present clinical cases about this procedure. Initially, in this patient, the panoramic X-ray that has initial 4 millimeter of the bone height. So I have to play a video about that. In this video, I have prepared the implant site by using a punch technique without a surgical procedure, without making an incision. After punching, I have used trephine, this trephine for a bone collecting. Autogenous bone is collected from the patient implant bed. At the same time, the implant bed is prepared by using this trephine. So the autogenous bone is collected. And after that, we'll use the osteotomes in order to prepare the implant bed, with proceeding from the smallest diameter up to the final diameter for the implant, and after doing the osteotomes. So after that, alloplastic material is mixed with the previously collected autogenous bone, and which is mixed with blood of the patient, and carried by using a bone graft carrier or a gun into the prepared area and lifted sinus floor. Following the augmentation, we use osteotome again in order to push the graft material upward, and the implants are placed in the area. This is the following the procedure, which the implants are placed after the augmentation of the bone and the elevation of the floor of sinus. These are a clinical view, which is loaded with the bridge, metal ceramic bridge, after 8 months after augmentation and implant placement. Another case, which is also presented by elevation of the sinus floor through transcrestal approach. In this case, we use only, we collect the autogenous bone by using a trephine, and then elevation of the sinus by osteotomes and the implant placement at the same time. The final procedure after loading with the prosthesis of metal ceramic bridge. What are the advantages of using a transcrestal sinus lift? It's a minimally invasive technique, especially if we are going to use without a surgery, only we use a punch technique. It provides more patient comfort and more primary stability and less morbidity, but there is one disadvantage, which we need the crest height should be at least 4 millimeters in order to provide adequate primary stability for an implant. Perforation of the sinus membrane may also result during the sinus floor elevation if we use an aggressive method or if we elevate the sinus too much. Introduction of the balloon technique during using the sinus floor elevation. It's the first introduced by Morey et al., which is the inventor of the balloon technique, minimally invasive antral membrane balloon elevation. So this balloon is used for sinus floor elevation. It's a less invasive technique than using the osteotomy. In this picture, it's used at first, we do the osteotomy of the implant and then breakage of the floor of the sinus. After that, the balloon is used for elevation of the floor and augmentation with the bone graft. And then after the maturation of the bone graft, we put an implant. This clinical case is taken from another journal, which they make the osteotomy, preparing implant bed, osteotomy, and then using a balloon for elevation of the sinus floor and augmentation with the bone, placement of the implant. This is the procedure after the implant placement, as well as the bone graft procedure at the same time with the implant placement. So advantages of using minimally invasive antral membrane balloon elevation. It provides minimally invasive procedure than using an osteotomes. In this case, clinical case, even if there was the initial crestal height, which was less than 4 millimeters, which was 3 millimeters, it provides an adequate augmentation of a bone or adequate height of the bone, which is 8.7 millimeter by using balloon technique. Other techniques for sinus lifting, if we don't have adequate initial height of the bone at, for example, 1 or 2 millimeters of the initial bone height, it's preferred to use a lateral approach or open window technique for augmentation of the sinus floor. So this lateral window osteotomy, which is also called modified Colwell-Lock approach, which is first introduced by Boyne and James in 1980. It's after opening the flap, we create a window, and then the bone or Schneider membrane is separated from the bony walls of the sinus, and after that the bone is augmented in between the floor and the sinus membrane, and after maturation of the bone we insert the implant. So in this case the implants, it should be inserted in a delayed manner after 8 months of bone maturation. Instruments which are used for the lateral window technique, they are Freres as well as the bone graft membrane. I have to present again another clinical case for this method. This patient initially was having 3 millimeters of the bone height, initial bone height, and there was a polyp in the sinus, but the polyp in the sinus doesn't interfere with our procedure. So we are taking the blood of the patient, collecting in a tube. So this blood of the patient is later centrifuged in order to separate the plasma. We are preparing PRF membrane by this method. These PRF membranes, which we'll use for separation or isolation of the bone from the soft tissue. Actually, we prepared the 2 PRF membranes, and the fluids which are collected from PRF membrane are mixed with alloplastic bone graft. So the advantage of using PRF, it contains osteoprogenitor cells which accelerate the bone formation procedure. A clinical case, opening of the flap, preparing the window for the sinus lifting, and then the Schneider membrane is separated from the bone walls of the sinus by using Freres from all over the area anterior wall and the floor of the sinus is separated. And after that, the previously prepared bone graft, which is mixed with PRF, is filled and augmented the space which is created in between the crest and the floor of the sinus. And condensed until it fully augmented the space, especially the floor and the outer wall of the maxillary sinus. After augmentation, the PRF membranes which has been prepared previously actually prepared two membranes in order to provide a double barrier. The first membrane is placed inside the bony walls and cover the bone graft. So this initial placement, or the first membrane which is placed inside the bony walls, will protect the bone graft from spreading out during blowing or sneezing. The second membrane is placed over the bone to cover the bone graft and separate the soft tissue or a mucosa from the window. After the suturing, post-operative panoramic X-ray, and this is the augmented bone and the polyp. It's not interfere with our procedure. 11 millimeter of the bone we have gained, and after 8 months we place the implants, and it's the final prosthetic procedure which is taken place after 6 months clinically, and the final metaceramic bridge. Another case which the patient was having the bilateral sinus lifting procedure through lateral approach after augmentation. Actually, in this area, I have a perforation in the sinus, which is treated by a membrane, again, to cover a perforated area. After post-surgical procedure, implant placement, after 8 months, clinical picture, and the final prosthesis. Another clinical case in this area, which was having only 1 to 2 millimeter of the bone. Again, sinus lifting has been performed through lateral approach, and we have gained about 14.5 millimeter of the bone. Implant placement after 8 months, and the final prosthesis metaceramic crown is loaded. What are advantages of using a traditional lateral approach? It provides an adequate stability of the bone and survival rate, as well as the adequate bone mass in the augmented area. But it provides an invasive surgical procedure, and there are a risk of membrane perforation and postoperative morbidity, especially if there are membrane perforation as well as infection in the area. Introduction of the balloon by using lateral approach. Balloon is composed of a latex and the tube which is connected to the syringe. This syringe is filled with a saline solution. Once the saline solution is injected, the balloon will be inflated in between the floor of the sinus as well as the Schneider membrane. So this is how it's performed through the lateral approach. After separation of the Schneider membrane, we introduce the balloon in deflated manner, and then it's inflated by injecting saline. Once we elevate the sinus membrane, we deflate again the balloon and then remove the balloon. Another clinical case, which was having only 2 millimeter of the bone height, but we performed a balloon technique through the lateral approach. Instruments which are used for balloon, this is the balloon for sinus lifting and bone scrubber, as well as frares. Bone graft and the collagen membrane is used as the balloon. Preparing the mucoperiosteal flap, elevation of the mucoperiosteal flap through cold lock approach. and using bone scrub in order to collect the patient autogenous bone, and as well as it provides thinning of the lateral wall of the sinus. Using round drill for preparing the window, drilling the bone until the Schneider membrane becomes visible. We have to be very careful not to perforate the Schneider membrane in this phase. We see the blue color of the Schneider membrane. And then initially we use the flares in order to separate the Schneider membrane through the bony walls of the maxillary sinus. Final separation. We create space in order to insert the balloon in a deflated manner. Now the balloon is used in a deflated manner and it's inserted through created space. Once we insert through the created space by injecting saline solution, the balloon is inflated in between the floor of the sinus and the Schneider membrane. This will allow the safe and non-invasive separation of the floor of Schneider membrane from the bony walls of the maxillary sinus. Once we finish our elevation, the balloon is deflated again. Now this is how we injecting saline solution, which is delivered through the tube to the balloon, the latex balloon, and it cause inflation of the balloon. After finishing our procedure, the syringe is aspirated, the saline solution, and then remove the balloon. This is the bone, autogenous bone, which was taken by using a scrap, which is mixed up with an alloplastic bone graft, as well as the blood of the patient. Autogenous bone contains more osteoprogenitor cells, and this mixed bone graft is augmented in the created space in between the sinus floor as well as the sinus membrane until completely and fully augmentation of the created space. Membrane, which is collagen membrane, is divided in two pieces. The first piece is used to cover the bone graft, which is placed inside the bony edges to provide double protection of the bone graft to prevent the bone graft to spread out of the window during sneezing or blowing of the nose. The second piece is used to cover the the bone and separate the mucous membrane from the bone. Final suturing procedure and the flap closure. Post-operative radiograph and implant placement after 8 months, and after 6 months, the final prosthesis has been loaded. The final panoramic X-ray after implant placement and prosthesis. We have made a study about the comparison in between the using a balloon technique as well as the traditional lateral approach for open sinus lifting. And in this study, we used 68 patients, and the initial height was from 3 to 5 millimeters of the bone and more than 5 millimeters of the bone width. And these patients are divided in two groups. The first group is undertaken a balloon sinus lift, whereas the second group undertaken traditional sinus lift. And after 8 months of the bone maturation and bone gain. We have a bone gain during the balloon sinus lift about 8.4 millimeter, whereas in traditional method, 8.1 millimeter of the bone gain. There was no significant difference in between two groups for bone gain. And after 3 years of the follow-up, the survival rate after implant placement and 3 years follow-up was 97% in balloon sinus lift, whereas in traditional method, it was 95.2%. There was again no very significant difference in between the survival rates, but there was a difference in the complications. In case of a first group, there was no any complications happened for this study, whereas the second group, there was 9 perforation of the sinus membrane, 4 sinusitis, and 3 graft failures. In case of marginal bone loss, in the first group was 0.86 millimeter, and the second group was 1.1 millimeter. There was again no significant difference in between the marginal bone loss after 3 years of the follow-up. As a conclusion, in both approaches, regardless of the approach we use, there was an adequate increase in the bone mass. And the difference was the balloon sinus lifting is a minimally invasive procedure, sinus lift, and this was reducing the patient trauma, and there was taking a less surgical time and minimize the risk of the sinus membrane perforation. It provides more safe and more effective result by using a balloon sinus lifting than in comparison with the traditional side window technique, but this requires more controlled clinical trials to provide to evaluate the efficacy and safety of this technique for appropriate implantation and the field of the oral implantology. But as a conclusion, both the techniques, whatever we use the balloon or whatever we use the traditional method, it's mostly technically dependent. It provides a more experienced surgeon. But the balloon will minimize the risk of the sinus perforation, but it doesn't mean that the perforation will not happen if we use a balloon technique. So thank you for listening.
Thank you so much, Dr.
It's a great pleasure to be able to participate in the 4th International Otorhinolaryngology Conference in Bangkok, Thailand. The title of our lecture is Health Frontiers Crossed by Temporomandibular Dysfunction and Orofacial Pain. Okay? I'm a graduate in dentistry from the Faculty of Dentistry of the Federal University of Rio de Janeiro, Brazil, and qualified in laser therapy by the Federal Council of Dentists here at Brazil. Do you hear me? Okay. Okay. Hello, how are you? Okay. I think I thought you hear me, okay? This is our latest publication on photomodulation effect on orofacial pain in Environ Journal Dental. Our research with photomodulation therapy investigates new technologies that can help in the process of controlling the signs and symptoms of people with temporomandibular disorder, TIMD, through approaches to control orofacial pain and reduce the inflammatory process, increase joint functionality, and improving quality of life of the patient. photobiomodulation is a non-invasive or minimal invasive therapy, promotes healing, reduces inflammation, and enhances tissue regeneration. Photobiomodulation, PBMT, has shown effectiveness in alleviating pain across various conditions, include arthritis, chronic pain, and post-surgery recovery. Without the last presentation about then the last presentation, the recuperation by surgery when you made application in this tissue, the healing this tissue became more fast to really realize this, okay? Excuse my English, no very good, but I will try that you and the other peoples understand my English, okay? The mechanism of action, the laser therapy or photobiomodulation, have biomolecular responses. The therapy triggers photochemical reactions, leads to increased collagen synthesis and modulation of cytokines involved in inflammation. Clinical effects, improvement in cellular signaling and reduction in oxidative stress, promote health benefits and accelerate recovery in tissues. Okay? This therapy can be used in numerous medical fields, such as sport medicine, dermatology, and dentistry, providing its wide range of use. We will present clinical assessments. This patient was diagnosed with muscle problem, okay, in TIMD. We apply photobiomodulation and ultrasound to treat this TIMD. Here are the results before and after treatment. C, increased mouth opening and pain relief. C, first session, the punctuation, okay, is 18, okay, and in final session, after 30 days, the punctuation is 0, and after 60 days, 0, 2, okay? This is OHIP oral health impact profile by this patient during the treatment, okay? See also the improvement with great impact on the quality of life by applying the OHIP 14. This article compares the effects of vacuum or ultrasound applied simultaneous with photobiomodulations in patients with TIMD, okay? Here are the two devices that you and my team applied photobiomodulation with others manner to treat these patients used ultrasound and vacuum therapy. Here we show how to apply the devices in these patients, okay? The graph shows that with both devices, there was an improvement in pain in patients on the right side. Here, the graph shows that with both devices, there was an improvement in pain in patients of the left side. Here, the graph shows that with both devices, there was an improvement in this patient's mouth open. Evaluation these results, we obtain in this study, we can say that laser therapy or photobiomodulation combined synergistically with vacuum or ultrasound improve the quality of life of patients with TMD, as seen in the evaluation through the whole HIP 14 questionnaire. You can see the better result, little better result, with ultrasound, okay? Laser combined with vacuum, the conclusion. Laser combined with vacuum or vacuum therapy or ultrasound therapy can be considered as a complementary or alternative treatment when controlling pain in the increased opening in patients with TMD. Now, I will speak to other problem related with TMD is tinnitus, okay? Tinnitus can be defined as an auditory symptom or pathology that is a subjective sound sensation unrelated to an external source of stimulation, okay? And can be a sizzle, whistle, pulsatile, doorbell, insect, butterfly wing, shower noise, waterfall, pressure cooker, perceptions. Tinnitus may refer to continuous, intermittent, variable intensity. And the cause about the tinnitus can have several causes, and one of them may be related to temporal disorder, TMD. In the scientific literature, we have proof of ligaments such as the malleolar discovered by the Brazilian Olympian Faisal, which is related to the internal auditory pinna. Look at this research where Professor Dr. Olímpio Faisal Pinto related about this, okay? 1960. It's a time ago, okay? Here, other figure show this relationship between ligaments and this problem about tinnitus. Okay? The conclusion about this, there was an anatomical and functional relationship between the human TMD and the middle ear, and future research is needed to confirm these findings using well-designed clinical studies. Okay, and there are studies showing the prevalence of tinnitus in patients with temporomandibular disorder, TMD. Okay, here one these various studies, okay, clinical studies. The most prevalent otological symptom associated with TMD was ear fullness, followed by otology, tinnitus, vertigo, and hearing loss. The prevalence of otological signs and symptoms is in adult patients with TMD is high. The most prevalent otological symptom in adult patients on TMD is auricular fullness. Okay? Here's another study showing this relationship between TMD and tinnitus in Journal of Oral Rehabilitation. Based on limitations of these studies include in the systematic review or results suggest insufficient evidence for or against conservative TMD therapies in change in otological symptoms. This article seems to me to be inconclusive on this subject. Okay, there are more 300 causes related to tinnitus. The American Tinnitus Association speak about this, and the origin TMD is called somatosensory related to muscles and ligaments. We taught dentists, okay, people, for a long time, dentists used occlusive plaques to treat tinnitus. Look at an occlusive plate used for patients with touch clenching, okay? Look, this slide, we conducted an experiment research comparing various types of treatments recommended in international scientific literature. We have this international publication made at MDPI for those who want to delve deeper into this learning curve for tinnitus treatment. This is the objective of this study, okay? And investigate and propose treatment options based on the effects of transmetal or cochlear with vacuum therapy, ultrasound, drug therapy, and laser puncture to treat tinnitus. We conduct an experimental research comparing these various approach to treatment the tinnitus. We have this in this is the evaluations were made with THI, okay, tinnitus handicap inventory. There are 10 groups treated Group 1, negative control, and Group 2 with laser in a transscopular way. Group 3, we applicated flunarizine. Group 4, we application flunarizine with photobiomodulation. Group 5, ultrasound and laser were applied. We applicate the ultrasound and laser. Group 6, we applicated the transmeatal external auditory canal with laser, okay, phototherapy. Group 7, we combined phototherapy with drugs or ginkgo biloba, no drugs, it's natural treatment with ginkgo biloba. Here, group 8, we combined ginkgo biloba, more detached laser, okay? And group 9, we treat with photobiomodulation with more time external ear canal for 15 minutes. And the last group is group 10 with laser puncture, okay? Here, a video about laser puncture application, okay? We can see the application in these points, okay? 6 individual points, a single yin point, okay? Here, left side. Okay, laser puncture. Excuse the sound by this assistant is very low. Okay, and here the results. We had promising results with photobiomodulation to treatment thyroids. Our current research has shown improvement in patients with difficult to treat symptoms of thyroids. Okay. And here, table of future studies. Okay. I suggest this. Each study highlights significant things in pain reduction and healing. Okay. Thank you for the opportunity to show the work of this team with the support of these research funding institutions in Brazil. We are interested in partnering with international research and institutions with research fund. Okay, thank you very much. Have a good Congress to you and the other partners and the presentations and the public. Okay, thank you very much.
Thank you so much, Dr. Vitar, for the excellent presentation.
And pre-cancer, and my whole job is to prevent the oral pre-cancer into cancer. It's just like the part of preventive oncology. So I will be presenting you few interesting cases of the oral and maxillofacial pathology related with the head and neck pathology. So the next slide, please.
Dr. Saurabh?
Next slide, please.
Yes, I'm so sorry for interrupting. We cannot hear you very well.
Can I get the next slide, please?
Okay.
So here is a 20-year-old female with swelling in the right mandible with a pulse discharge. The radiographic shows us multiple radiolucents in the mandible, and there was a bicortical expansion. Next slide. So here you can see it's a multiple, it's a radiolucency in a right mandible, and you can see the bicortical expansion of the right mandible prominently. Next slide. Next slide, please. So the impingement biopsy was done, and it was reported as a dentigerous test.
Dr. Saurabh, I'm sorry for interrupting. Your voice is not clear. Can you move to any quiet place?
Okay, fine. Once again.
Okay.
I'm audible now? I'm audible now?
Yes, we can hear you hardly.
Okay, because maybe some internet
Yes.
connectivity issues, maybe because of that. But I'm audible now to you?
Yes, we can hear you.
Okay, fine. So the incisional biopsy was done, and the diagnosis was given as a dentigerous cyst or OKC by me. I'll explain you. You to move to the next slide, please. So here was the enucleation done of the lesion. Here you can see the fossilizations of the mandible, and you can see a clear-cut blood-filled area in the right mandible. This is a surgical site when the surgery was done, followed up by the diagnosis of odontogenic keratosis and dentigerous cyst. Next slide, please. So this is a cystic lining which was seen after the enucleation of the tumorous area from the right mandible. And it was been removed in a fragment. One was in toto excision and the rest was removed in a fragment. Next slide, please. So the people who's listening me, if they have interest in histopathology, you can see here the plain cystic region with a thin lining which mimics to a dentigerous cyst. Next slide. Okay, so in this soma with the cystic lining, can you see there are the islands of the odontogenic epithelium? So I wish someone can comment on this. If someone can comment, then which I will be happy to hear. So here you can see the stylotriticulum cells, seems to be like, odontogenic origin. So from this slide, we know that it's odontogenic. Next slide, please. It's odontogenic. It's not a typical cystic. It's a mixture of a cystic lesion as well as the tumorous lesion. Next slide, please. Next slide. So here you can see the odontogenic islands in a stoma. And here you can see a good duct inside the stoma with the big epithelioid cells in a stoma. Next slide. So anybody in the audience, if they want to give a diagnosis, it is resembling as a initial immature root formation stages. So this is not actually a cyst, it is a tumor. Which tumor is this? Next slide. Okay, so this is not us, it is a unicystic ameloblastoma with a type 3 of variation, which is neural, because you can see the islands are growing into the stoma. So it is a unicystic type 3 ameloblastoma, which resembles to the conventional ameloblastoma. Next slide. So it is unicystic ameloblastoma type 3, and the treatment is just not enucleation. The treatment is to resect the mandible. Ameloblastoma, it resembles to. So the conclusion of this case was, even if you see that if thin cystic lining in a biopsy, you just don't have to jump to the diagnosis of unicystic ameloblastoma. You should always think there would be a possibility of the type 3 unicystic ameloblastoma, which is neural and which resembles to the conventional solid ameloblastoma, which have the treatment of not enucleation. You have to resect the area instead of just enucleation. Next slide. Thank you so much for this space. 12-year female with the right parotid swelling in the face was seen accordingly. Next slide. So here you can see a good amount of solid area with more solid pattern of the bluish cells. Next slide. Next slide. Okay, so what you can see the salivary gland with a capsule and blue cell in a solid area. Next slide. You can see here the multiple iron of the blue shell in a background of multicellular monomorphic type of cells. Next. Yeah, so this is a good amount of vesicular nuclei in islands of bluish cells with a background of the substrate. So both kinds of vesicular appearance, isn't it? Next step. So differential diagnosis. You can think of cytoblastoma, synovial sarcoma, adenomatized like having sarcoma, rhabdomyosarcoma. Next slide. Oh, so there was a CK positive genes, AA3 positive, synapse was positive, P40 positive, and RES-MA-DE-FON, beta-catenin, and SMA muscular marker was negative. Next slide. So this was a even histochemistry workout time. So mix-2 positivity, good amount of mix-2 positivity. So you can mix it. Now you might know the salivary gland, parotid, big swelling, blue cells, nested cells, vesicular nuclei with this positivity. Next. Here you can see the membranous positivity or the visualized type of islands of this gland. Next slide. Okay, so I think almost the people are aware of the diagnosis. The first BWSR1 was done, and we can see the nuclear and tumoral fusion and rearrangement was detected. Next slide. Obviously, so having sarcoma, but admancinoma like having sarcoma. So once you can see the blue cells, you have to distinguish whether monomorphic or multimorphic, followed by your immunohistochemistry panel. Any questions? Kindly notice. Next slide. I think it's clear extending to the orbit and nasal cavity, present in the nasal blocker with epistatic investigation schema. Next slide. Here you can see a good lobulating mark measuring approximately 4.2 to 4.7 centimeters. The right maxilla extending the sinus and eroding the adjacent surface, the nasal cavity. So it's something maxillary tumor which extends the nasal cavity and disturbing the whole orbit. Next slide. Again, you can see the sliding gland which encapsulated, you can see the false encapsulated tumor with good amounts of bluish solid cells similar to the last page. Next slide. Yeah, you can see the necrotic area with the adjacent bluish eye. Next slide. Yeah, you can see the two cell population. One is more bluish, one is pinkish, and you can see the bicellular morphology of the cells. Next slide. You can see the clear cells with peripheral of the basaloid cells and the fibrostoma. All right, so you can see the central necrosis with the peripheral basaloid cells and background stroma with a two-cell population. Next slide. Okay, so here you can see the clear cells. There's some kind of the bone which is invaded by the tumor and the stroma. Next slide. So obviously, the differential diagnosis would be, as you can see, a ductal area obviously described with the carcinoma, neuroendocrine carcinoma, obviously the squamous cell carcinoma poorly differentiated and next carcinoma. Next slide. Here you can see the good amount of diffuse P40 positivity, INI was present, BRG1 was present, and SARS-CoV-2 sinusitis. Next slide. You can see the good amount of nut positivity. So nut is what? Nut is what? You have to relate to the future in females. Next slide. Okay, so the diagnostic part. Obviously, the nut carcinoma, female and somewhat associated with a smoking history, the involvement of the sinonasal area along with the maxilla, and your sign-up or the markers was negative. To rule out, but you ruled out SMART B1 deficiency, sinusal carcinoma, which was described in last presentation. Thank you. Next slide. Quantity of male with the right maxilla extending to the nasal cavity. Again, the nasal obstruction and the swelling in the right face. Again, you can see the erosion of the right maxilla with the nasal cavity extending to the nasal and sinus region. Next slide. Next slide, please. Okay, you can see the whole bluish area again with a good amount of humidity and necrotic area. Next slide. You can see there is a little proliferation. It is like a papillary growth. And can you see the cells are monomorphic or multimorphic? You can see the next slide for that. Again, the next one. Okay, so can you see the pinkish area, but the cell is monomorphic. Can you see the elongated cells like the papillary growth? Next slide. Here comes a beautiful monomorphic cells elongated with nuclei elongated and the central foci with the central stoma and trapsid. But you can see still the morphology is maintained. Next slide. Yeah, you can see the multiple atypical cells and atypical cells, typical mitosis seen in this area. So this used to be neoplasm, high-grade neoplasm of the salivary gland. Next slide. Okay, so what you can differentiate diagnosis? It's non-keratinized, obviously, it's non-keratinized, understood from the single papilloma because crystalline papilloma, and actually with which is multi-phenotypic convolution carcinoma. Next slide. Here you can see a beautiful C-K7 positivity. So it gives you the particular origin, P40 was positive, INA was positive, positivity was and sinus so it was negative. So it rules out what? PPF sinus was negative and INA was positive. So something of the origin. Next slide. There's a beautiful P16 positivity. Next slide. Can see the beautiful P16 positivity, complete epithelial cells, completely nuclear as well as so membranous positivity as well as cytoplasmic positivity. All cells, almost all 99% of cells are positive, and the stroma is negative. Next slide. So what is it? It is like multi-phenotypic convolution carcinoma with HPV because P16 was positive. Such type of the tumor which has such kind of papillary growth and P16 positivity, but P16 and CK7 and P40 the positivity have to be screened for the multi-phenotypic convolution carcinoma. Next slide. Next. The last screen section for a 42 male with the right nasal maxilla and again the obstruction in the right nasal area with the typically breathing. Next. You can see a beautiful blue cells. There's a right side on cells, the island, the streets, fibrostoma. Okay, you have to please correlate with the previous case because all the case hasn't present incorporated considering the site specificity of the conference and so that you can relate and get this next. You can see here the pinkish cell with the vesicular nucleus. So the previous side was this is pink, and this is more vesicular, usually with vesicular nuclei and the pinkish stroma. Next slide. So yeah, you can see the structure which is separating the left side blue cells, right side pink cells. So left side blue cells are basaloid. Right side pink cells are rhabdoid. So can you imagine the tumor with both rhabdoid as well as basaloid appearance? Next slide. Yeah, you can see the rhabdoid cells with so the CK was positive, AEG positive, C40 positive, and left and synapto negative. Again, it's a particular origin, so it's a carcinoma. Okay, from which carcinoma we are saying left is negative, synapto again negative. Next slide. Yeah, so you can see the INI is positive in the stromal cells, but it is negative in the tumoral cells. So it is INI negative, whereas epithelial positive. So I can name it. Very simple. It's INI deficiency or smart V1 deficiency. It's a carcinoma. Next slide. So yeah, it's a thing. Okay, so the next last presentation device is important because it has a structured treatment plan towards the target of therapy is important. I was trying to make difficult things, which is both treat and can difficult prognosis and teaching. So I think any questions we can discuss. any partial sheet. Thank you so much. I hope you enjoyed the lecture. It was all oropharyngeal and sinonasal region manifested fixed of cases, which has to be considered during our diagnosis and treatment planning, and which helps the clinician to give a proper diagnosis and hence it's beneficial for the patient to have a good lifespan and a good survival rate.
Thank you so much, Dr. Saurabh Nagar, for the presentation. Any questions?
Medical Center, as well as I have done my aesthetic training from IIT Sweden. So today I will be talking about incorporating facial aesthetics in ENT practice. So sorry for the disturbance. Just allow me a moment. I'm really sorry.
Dr. Manya, I'm so sorry for interrupting. Please unmute yourself.
Really sorry for this interruption. So I belong to Central India. I work in medical college. I work as associate professor in Government Medical College, Raipur, as well as I run my own aesthetic practice at my center, as known as Maya Aesthetic Clinic. So what are the aesthetic procedures which we can do as an ENT surgeon? So there are a lot of aesthetic procedures which are just daycare, as you all know. And why I am emphasizing that we can do aesthetic procedures in ENT is that we are the most well versed with the anatomy of ear, nose, and throat, and as well as neck. So we are ear, nose, throat, and head neck surgeons. So we come across with the anatomy, with the all the blood vessels, musculature very well, and even I think better than other branches. So this is one of the things which we can easily include in our practice. So the procedures are like endless. You can go for Botox, fillers, thread lifts, medifacials, then autologous fat grafting or stem cell grafting. We can go for even semi-permanent makeup if you have an assistant or if you are willing to do yourself. You can go for tattoo removal, fibroblasting, earlobe repair, hair transplant. You can do dimple creation, blepharoplasty, minimally invasive facelift if you don't have a facility of GA at your place. Then neck lift, threads. So and also there are a lot of procedures. So I'll be just going through the normal procedures what I do in my clinic, and you can also incorporate it gradually to not only to increase the revenue but give a patient better outcomes as well. So coming to the first one, um, these are medifacials. In our part of country, the like since last 5 years it has become famous. Earlier it was not there. So in this, what we do, we just use antioxidants, multivitamins, or AHAs, BHAs, and radio frequency or ultrasound or a micro current based device or LED lights, which helps not only in cleansing or exfoliation or hydration, but it brightens and it rejuvenates the skin. And when somebody get it done regularly, it turns the body into anti-aging mode and decreases your aging and signs of aging. So there are like n number of options and n number of machines available, and you have to choose your machines, your protocols, the facials according to your patient's need and their choice. So this is like a video of a glutofacial. So we have n number of medifacials. It can be a hydra facial, glutofacial, LED light facial, and so on. And you can get a before and after result immediately. You will get some difference even with a single session of medifacial for sure. Because once you use right amount of product for a right patient, you're bound to get the results. Even with the microcurrent or myolifting facial, if you see that the patient is able to have some improvement in her, nasolabial folds, her like eye wrinkles are decreased, then corner of mouth appears better as compared to like this picture. So these are the results which will, although it will give a temporary result, but it will be better than going to a salon, and it will definitely generate revenue. And best part is that you don't have to do it. You have to keep your staff, just guide them, choose the facial and products accordingly, and they will be earning money for you. Why the next slide is not moving? Wait. Now, when we used to do our residency, everybody used to do a part preparation. And this is somewhat, it is also similar to doing a part preparation. It is called as derma planning. In this, we use a 15 number blade or 23 number blade. And through that, we just remove the peach first. Sorry. So we just remove the peach first through it. And it not only remove the dead skin piece first, but it gently do a micro exfoliation. So if a patient is opting for a peel, it enhances the penetration of the product. And if you are going for a medifacial, again it helps in improving the outcome of your simple medifacial, and the patient is good to give you a clear look after this. So this is a before and after result of a derma planning, which the patient has underwent. Now coming to another lunchtime procedure which just take 15 minutes is a mesotherapy. And what it involves is it's a non-surgical procedure for skin rejuvenation, and it can lead to you can virtually do it on any part of your body. Say for your face, for your stretch marks, for your acne scars, for wrinkles, for hair growth, as well as even the cosmetic gynecologists, they use it for private part lightening and removal of fine wrinkles. So depending on the product which you are using for mesotherapy, say it's a hormone, vitamin, minerals, or exosomes, PDRN, or even stem cells injection. If you are doing a fat grafting, you can inject nanofat like this. So it creates a wonderful results with just 3 or 6 sessions to the patient. And if the patients they start early, they will not need botox and fillers or other surgical facelift in future. It will decrease or delay the aging if the patient get this done, and with the proper home care, it considerably improves the amount, the quality of skin and the texture of the skin, and increases the collagen. This is I used the Duo X81. So as you can see, the mesotherapy can done for dark circles, for forehead lines, for marionette lines. But mind you, if a patient is already having a sagging, it will not create a lifting effect. It will just increase the collagen. It will create a more firmer look, but there will be no lifting as of now. So you can see the before and after of a result of the mesotherapy. This is was done by Dermapen 4, the 3 sessions. You can use this for hypertrophic scar as well. It creates a wonderful result when we combine with local intralesional steroids. It creates, almost smoothened out appearance of the patient. This patient photograph has been sent by patient, not I have taken it directly. So there's a little bit variation in the quality, but it definitely improves the outcome. Then if you see for acne scars, for hyperpigmented spots or PIH, again it works wonderfully when you combine it with the good home care or serums. So this are a few before and after results of the mesotherapy. Even for open pores or orange peel like the skin if the patient is having, you can do mesotherapy, combine it with mesobotox, and the patient you will end up having a happy patient. Now, another very wonderful effective lunchtime procedure which you can include in your setup is micro needling through radiofrequency. In the previous slides, I have just shown about a micro needling in which we are just, creating a micro channels. But once we combine it with the power of a radio frequency, it its power just increases. It increases at least 200% of collagen is increased in the 3 sessions itself, and the body your skin is turned into anti-aging mode. So if somebody starts it in very early age, say 25 or 30, because these days the aging doesn't depend on the physiological age you're having. It also depends on the kind of patient's lifestyle, how much is the screen time, especially in our kind of area. People, they have a lot of aging in their eye region. They have even young people of 20-21 years are having crow feet and laxity of upper eyelid. So if we started early, it creates a very nice result, because as we grow up, we all know that in our 20s and 30s, still the collagen are organized. We have good amount of collagen and elastin fibers in our skin. But as we age, their arrangement gets disrupted, the fibers break down, and our skin lose firmness. So this is one of the very effective procedure which, if done started early, it don't lets your collagen get destroyed or lost due to aging, and it maintains it. So you can, this is like a non-surgical rejuvenation here. If you see carefully, the patient's brow is better. And I have not used any filler. I have not used Botox for this, but he has got significant improvement in his skin texture as well as the level of eyebrows. Eyebrows drooping was also improved. This was just this was the result of just 2 sessions. They are like one more session to go. I hope that his eyelid will also improve. So it depends on what kind of a solution or a serum you're using with MNRF, either a PRP or exosomes or any kind of hydrating boosters, or you can combine them with meso solutions of hyaluronic acids. So this help a lot. This help a lot. So now coming to chemical peels. Peels are Peels are something, which again, it will just take 3 or 5 minutes of the procedure, and you will be good to go with very nice results. And you can, like, mind you, I think every patient of you can do peels on them, because, everybody wants to have an anti-aging, brightened skin without any scars or pigmentation. So chemical peels are just, they will take just 5 minutes, and they will be able you will be good to go. So this is a result of before and after of a lip peel. For example, if somebody is refusing for fillers, or they don't want to go for a semi-permanent makeup, if they have allergies to pigmentation, so you can offer them chemical peels for lip as well. I use Ferolac Dubai lip balm, and it not only decreases the pigmentation, but it decreases the fine lines and the wrinkles on the lip, and improves the elasticity and hydration of the lips. Now again, another before and after of a acne patient. This, we have used salicylic acid peel for him, for her. So even with a single session in a 1 week, you will be able to give a good amount of result when you combine it with LED lights. So it definitely rejuvenates and give you very brightened skin. The pigmentation is improved, the quality of skin is improved, and it hardly takes just 5 minutes of your time. So either you can do it, or you can train your staff, and they can do the peels and the other this procedures under your supervision. So this is again the before and after result of a peel. This is also of a single session. You can see the dark circles are considerably reduced, the pores are reduced. That we have a happy patient with that. And if there's like a melasma, or if the PIH is more and patient is able to afford the cost, then you can go for a premium grade peel like a Cosmelan or a Dermamilan peel. They have also a very wonderful results. If you see, this patient has gone for Cosmelan. Not only her skin tone has brightened, her pigmentation has improved, and in near future, this will also go with the proper home care if she follows it. So these are the procedures, they will just take 15 to 20 minutes and give not only a good revenue, but also you're bringing transformation to a patient. So you end up having a happy reputation and a happy patient, and patient, your rapport is built with the patient, and then you can convert them for facial aesthetic surgeries depending on your expertise. Now again, Botox. I started Botox for if there are some patients who want to, they have a flared while smiling, or they want a thinner nose, and some people have a lot of comedons and oily skin on nose. Generally, what happens? People give isotretinoin so that the sebaceous gland hypertrophy it can get decreased, and it creates a thinning of nose. But I don't like to give isotretinoin for a longer duration of time, not more than 3 months at least. So I prefer either a Botox or a plasma sculpting for my patients, or either I'll do a fibroblasting for my patients so that it gives a slimmer and a slender nose for them. So I do Botox not only for for eyebrow correction, eyebrow lift, or crow feet, or facial rejuvenation. I also use it for hyperhidrosis, for calf tox, for Barbie Botox, which is also called as neck slimming. We have a lot of patients who have who have cervical spondylosis. They have chronic cervical pain due to their wrong postural habits. So in that patient also we do Botox for the paraspinatus and trapezius muscles. So it relaxes a bit and it improves their lifestyle. Even with the patient with a chronic migraine who are not responding to medication. Being an ENT, I come across with a lot of patients who have headache because of sinusitis or DNS. But there are a class of patient who don't have these diseases. They just have migraine, and if their migraine is not responding to the medication, they you can go for a Botox for the temporalis muscle and masseter muscle. It definitely improves their quality of life and decreases the pain and episodes as well. They say that they have encountered less episodes when they have gone for the Botox. So another thing which you can opt for your practice are fillers. uh, this is like with just 1 ml of filler, you can do like a little of chin augmentation or under eyes improve. This I did in a live demonstration on a workshop. So this patient wanted us the subtle differences. I use very minimal quantity of fillers. Why? Because they are not absorbed completely. One, the y cross residues are there, so eventually people they land up. So I prefer more of a high rating boosters and collagen induction therapies rather than injecting a lot of fillers on the patient. I avoid it. Now this is before and after a picture of a patient in which I have done high rating boosters, and you can see there's a subtle difference. The patient is looking more hydrated, more dewy with a glow, and it also improves the quality of skin. Now, this is picture of another patient in which I was doing a high reading boosters. These are again like 10 minutes procedure. Your patient, your staff will do the numbing and all, and with proper consent, this is done in just 10 minutes, and you can improve the quality of the skin of the patient, and there will be no side effects, and we'll end up having a happy patient. Like, and in this patient, for example, I have done high reading boosters and just 1 ml of filler on the high cheek area, so that she has gone and she was very happy with it. And I prefer the safety of the patient very much. So I try to do, I avoid doing injection technique. I prefer doing a cannula. So it, although people say that it can never, traumatize the blood vessels, but there are still chances. So I don't, blindly follow everybody. But even with the cannula also, and if I'm working on an area where it is more vascular, I do take precautions. I do aspirate. So, but it Canada definitely it helps in improving your technique. It decreases the bruises. Your patient doesn't get bruises. Your patient doesn't get multiple pricks. So he prefer you as an injectable or aesthetician when you do it with cannula. So this is a very natural looking results we can create with the lip fillers. You can see the patients had an asymmetry in the lips, and now she has got a very natural luscious lip. And this we have done with just 1 ml of filler. So always try to choose your patient wisely and never over inject, because if you do that, you can end up spoiling even beautiful faces of the world. If you see Aishwarya Rai or Sushmita Sen, they have got like most beautiful faces, but still they had over pumpkin face or a overfilled face syndrome. So use the amount of fillers or the procedure very wisely. All right. Now coming to another case, this patient has a under eye hollowness and sunken-ness. So she has got dark circles as well as under. So I did a filler for her. So this you can see a before and after result of this. I'm so sorry for the interruption. This is again a case of a nose filler or liquid rhinoplasty which I am doing. So we do it in this is again a very safe procedure for the patients who are not doing liquid rhinoplasty, who don't want to get surgery. So this is very nice procedure to go for. Now, this is another patient who has got thick nose, but again, to this patient, we have to explain them that there has to be if they're not willing for the surgery and they want immediate downtime, or if they're skeptical about getting the procedure done and they want immediate result. So liquid rhinoplasty helps in creation of a idea of how patient is going to look after the procedure. All right. So this is one which is it will enhance your practice. Being a facial plastic surgeon and an ENT, I love doing rhinoplasty. But whenever there is a demand from the patient and they're doubtful, I try to give them idea and not force them for getting the surgery done. And also with I explain them what are the pros and cons of getting a liquid rhinoplasty and all that. So it's a very nice, quick 2 minutes procedure for your patient. So for the hump also and for nasal hump, or if you a patient wants a slim and centered nose, or they were wanting for a minor correction. For example, in this patient, I did a thread lift. She was very scared of surgery. Now she is ready to go for a surgery. So it's like that. So this is again a patient. She also want a very minor correction. This is another patient. She has got thick nose. So you can do chin augmentation. You can do under eye filler. You can excuse me. इन लोगों को ले जाओ ना बच्चे लोग को. So sorry for the interruption. Yeah. So another procedure which you can have, or equipment which you can have in your clinic is lasers. Now this is a Q-switch laser which you can combine with your medifacials. It's like a laser toning, or a carbon peel or tattoo removal or skin rejuvenation or hair bleaching. And even it can be used for freckles, hyperpigmentation, brown spots, congenital pigmentation, like that. So this is again just a 10 minutes procedure. Sorry. So this is this is a like just 10 minutes procedure. Patient are super happy with it, and with like multiple procedures or multiple sessions, you are bound to have a good skin rejuvenation for your patients. Why the slide is not turning? Yeah. So with depigmenting laser and in combination with peels, you are bound to get results with like a decrease in pigmentation, better skin tone, decrease in open pores, the melasma or the PIH gets reduced, and you end up having happy patient adding extra revenue for your clinic or your setup. So this is again a session of depigmenting laser along with few peels and good home care. Mind you, home care is very important for the patients, whatever you are, doing treatments. If they follow it religiously, they are bound to have very good results. But they should follow it. So this is also a single session of before and after of a laser depigmentation for this patient, old lady. So even with a single session, if you observe it, that decreases wrinkles as well. The skin gets rejuvenated, it gets depigmented, and if we are on repeated sessions, you get better quality of skin texture and overall the thing. Now another machine or equipment which you can incorporate in your practice is laser hair removal. Yeah. So we all know that everybody gets a hair removal done. For example, all the females, they can waxing or they use razor and waste their hours. Even men also, like a lot of people, they do beard shaping, or the gym goers, they want their hands and chest to be clean. So everybody is a patient for a laser hair reduction. So if you keep in your setup, you can your staff will be doing it. You will be setting up the protocols for the patients, and it will be like running in a very good mode, and everybody is a patient for laser hair reduction. This is a very good option to keep. Like a lot of you have you can either hire a technician yourself, or you can, because being a surgeon you cannot do everything. You can have a med spa kind of thing as we have in US, Europe and Turkey. Most of the surgeons, what they do, they keep a med spa over there. Their staffs are running all that, they're guiding them, and from there they're getting conversion of further surgeries. So even you can use this laser hair removal for blackheads on the nose. There are many times the tiny hairs on the nose are considered as blackheads. So you can use it for any for a private part. You can combine and collab with your cosmetic gynecologist and combine them with other procedures as well. And this is again a picture of a hand rejuvenation in which we are injecting hydrating boosters. And you can see the immediate before and after result of the hands of the patient. They look much young, and these days, due to poor lifestyle and decreased hydration, people, even young ladies are having in their 30s and 40s are having a lot of wrinkles and loss of hydration and volume from the skin of the forehand. This is again a 15 minutes procedure, almost painless procedure. You don't require any anesthesia for that. You have to just numb and do it under local anesthesia, and 15 minutes you are good to go. So either you can go for hyaluronic acid boosters repeatedly, like once a year, or you can also convert the patient for fat grafting. So it depends on your expertise. You can do that. Even these days, Renuva is coming, which is almost like a autologous fat, but you don't have to harvest it. It's little costly, but again, patient don't have to go under the knife for getting it done. So now coming to the hair restoration. Now, hair restoration itself again is a topic, is a big lecture in itself. So I will just do it in a very short time. So you have got QR678 as a major solution. You can do stem cell therapy, platelet-rich plasma you can do, but PRP is not that effective as growth factors and exosomes are. And even nano-fat grafting, if a patient is giving consent, it's again a wonderful procedure and gives a very nice result. And if there are some patients who don't respond, or all right, oh, don't have a time, and I have to look young, my beard should look nice, or they want a little denser look. They're not bothered about too much for growth of a hair on the immediate time. So you can also go for a scalp micropigmentation, which will create a illusion of having hair on the scalp or beard or whatever area the patient wants it. And if they are ready, you can also go for a hair transplant. You can either do yourself, get your training, or you can collab with any of your dermat friends or maxillofacial or plastic surgeons, whosoever you're doing it. So it's like that. So this is again a very big segment, mind you, and hair loss in India is very common, and everybody wants to look good, look young, and androgenic alopecia is very common even in young guys due to cigarette smoking, alcohol, and drugs and lifestyle changes. So hair loss is something which everybody goes through at some point of the time, and so everybody almost unlike 8 on 10 patients are for your hair loss. So you can go for a scalp revival spa and put up as a Keravive of a hydrofacial treatment. You can do scalp peel, you can do PRP, you can go for LED light or Celluma for hair growth. So there are a lot of options for hair growth as well. So we can do hair threads as well. This is was result of my hair transplant after 6 months. Again, hair growth. And another option which you can have is as a semi-permanent makeup. Either you can hire a technician or you can do it yourself. I learned it for my patients of vitiligo and cancer who suffer from matarosis. So again, this is again a 15-minute procedure. Your technician or your staff can do this for your scalp micropigmentation. And what happens, it not only creates a very beautiful look for the patient and regains the confidence of patient. When you do it rightly, it also creates an illusion of a brow lift also. So there are times when you do a correction and you are good to go, you don't require brow lift for the patient. At times this happens also. So you can choose the patient. I learned that just for my passion to serve patients of burn and acid attacks, so that you can add some beauty to their life to rehabilitate them. Otherwise, this is done by non-medical people, so I'm absolutely fine with that. I love creativity, so I do. Then you can also do it for patients with vitiligo who are, who are tired of eczema treatment. They don't want to go for lasers. So you can go for this semi-permanent makeup for skin for particular spots. So just to act as a camouflage, and it will last for 2 years after 5 or 6 sessions. And meantime, you can go for a autoplasty or a nasal removal or minor surgical procedures such as scar revision, mole removal, xanthelasma removal, dimple creation. So, and number of facial aesthetic procedures which you can do in lunch just as a lunchtime procedure like a blepharoplasty, or if you're going for preservation anaplasty. But generally in India, we do rhinoplasty as a admission. That's why I haven't, put up this in this slides. So another revenue generating procedure is your IV depigmenting therapy. These days, patients have, loss of immunity, especially after the COVID era. Everybody's immunity is, jeopardized. So when we combine the glutathione with the other antioxidants like acetylcysteine, alpha-thiiotic acid, alpha-lipoic acid, it creates not only a wonderful depigmentation and an antioxidant for the patient, but it also, decreases the anxiety, it elevates the mood, it makes the sleep cycle better and brightens the natural skin tone. And we add up with collagen, so it creates a very wonderful result. You can see that the scar is also gone. Scar is barely visible after this glutathione and collagen induction treatment, and you can see visible lightening with combined with this treatment. Now, another treatment which we can go for is a fibroblasting. Now, I'm not too much propagated of this because this is associated with the, PIH. Because in India, patients don't use sunscreen. They are bound to go in that because of the tropical climate, and they have tendency to have a pigmentation. But nevertheless, it's not that it's not effective at all. If a patient doesn't want to go for a blepharoplasty or a brow lift, and is ready to bear the downtime, so you can also go for a plasma fibroblasting, which in turn create some lip lift, it constricts the skin because of the thermal trauma. So it will give you a little bit of constriction of the skin and increase in the collagen of the skin and leads to tightening. For example, in this patient, she had a lot of acne prone skin. Her since her childhood, her acne were not resolving. She wanted a thin nose, but at the same time, she didn't wanted to go for a rhinoplasty surgery. She didn't wanted to go for a threads. She was scared for that. So we did a fibroblasting for her, and it not only decreased her acne, but it improves her, this appearance, bulbous appearance of the tip. So, and she was very happy after that because her acne episodes also decreased. Her nose was looking beautiful. But we also explained regarding the PIH. So this is how it heals. So if you're opting for this, you should counsel the patient accordingly. This is before after of eyelid for the hypomelanotic, we just do a jet peel with this. This again, he is a 80-year-old male who came for like do a neck lift for me, and he was a diabetic. He was hypothyroid. He has hypertension and metabolic syndrome as well. So I chose not to do surgery, but to perform high rating boosters and fibroblasting. This is just a session. This is the result of first session. So I could not create a great result, but I can give him an acceptable neck. And in like once, this is just after of like 2 months only. Once the 6 months will be done and we'll be repeating the procedure, it will improve further. Another procedures which we do are thread lifts. Thread lifts we can do. Mind you, you have to choose your patient carefully. Then the patient has to be in your middle-aged females, not wanting surgery, and they just want a collagen induction, and there is no sagging. Mind you, with thread lifts, you can create a very minimal, effect of lifting. Threads are not for lifting. They will just give, when you combine them with fillers, they will give you a lifting look. That's it. So don't misguide them or increase your expectation. You have to counsel them rightly, what kind of result you are going to deliver to the patient. Like for example, this patient came for the facial slimming. All right, she has undergone hypho in multiple centers over here, the high focus ultrasound for face slimming, but she was not getting the results. So what we did, we just a little bit of thread lift for her and a little bit chin augmentation. And with that, in the single session also, she had a wonderful result. She was very happy with that. Again, this is we did a thread lift for eyebrows correction and a little bit of filler. So you can see you can do it in just 5 minutes. This we did a full face rejuvenation for this patient. She had a double chin, a retinopathism, so she wanted this to get hidden. So what we did a little bit of chin filler, a little hydrating booster and threads, and some nose filler, and a very little remnant volume. We do it in we inject in lips as well. The remnant of hydrating boosters. So she was she was very happy patient after this. And apart from that, this is one of the tool like analyzers you can keep, or a facial ultrasound you can keep in your clinic, because these kind of things really aid to your practice. You can actually follow up and come to know whether the patient is following your protocol or not, your if the patient is lying to you or not. Because in aesthetics what happens, like not in abroad but in India, patients are very skeptical about it. They don't tell you that they have undergone fillers or they have undergone any procedure. So if you do it, you had in your tool, you are good to go, and you know it right, that where you have to inject, where you have to not. You can use the, you can learn, and you can know the anatomy well. And also this analyzer, they they compare with before and after results, like if the patient has actually applied sunscreen or not, they have actually used serums or not. So in that case, you are able to guide your patients properly. You can work on your patients properly. It's not just a show off for a clinic, but it also helps that how much score your treatment protocol is going in the right direction or not. That's why this instrument is important. So we advocate our trainees, whosoever fellows come to us for learning facial aesthetics, we do advise them to have it. And this is a problem of here. The people, they don't tell it if they have got anything. I mean, even in my friend circle also, they will just get the glutathione sessions done. They will get fillers, botox, and periods done. And if anybody will ask you, oh, how you're glowing, they will not, oh, I'm doing a face yoga. So just learn it in your mind that yeah, this face yoga and all that, everybody cannot do it rightly. They have some effect, but they cannot create a very drastic changes to your skin. So it's good, but to not that level. Natural things are up have a certain limitations. So this happens, so you have to choose your patients rightly. Now again, this was another patient. She has melasma, and she is again a cabin crew. She has just apply eye makeup and lip, and she underwent depigmenting therapies, IV glutathione, and the result we got was very wonderful. She was very good follower of the home care, so it was like, oh my god, it's just her skin just improved tremendously despite of being in 35 and 36 of age. And the given conditions of the as the like sun of India, the kind of climate we have. So you get good results with proper home care, with proper serum and combined efforts of the aesthetician as well as the patient. And even if they're not willing for any procedure, they're not willing for surgery, even with the home care also, they can have good results. So always mind you, you should choose your patient wisely, and it should not be like that. Oh, you are a surgeon, so you will not offer them, non-surgical procedures. Being a surgeon, you should be having, you should be well versed with all the procedures, and have it on your armamentarium and offer them all. Let them choose. Let their choice be, surpass the ball. So this is the next stage of fellowship which we conduct. So in this we give a hands-on experience of not only Botox fillers, thread lifts, but we give them experience of everything like fibroblasting, MNRF, medifacial, peels, and so on. So if anybody wants to connect with me, they can just connect me through the Instagram or WhatsApp on the number shown below, or can email as well. And this is the 11-month long-term fellowship we do. We are certified with Indian Society of Facial Plastic Reconstructive Surgery, as well as we are certified with IABDEC. It's the International UK board. So these are like where I've got trainings and accolades. And I'm really thankful for my mentors, Dr. Brajain Base, Dr. Narayan Jankiram. This is my alma mater where I learned and did my post-graduation. And another one is a medical college where I work right now, and this is my happy place, my clinic. So where I do all the aesthetic procedures. So being an ENT, I do all the surgeries in my hospital, and I do all the aesthetic procedures, surgical as well as non-surgical, in my clinic. So for me, patient satisfaction is above all. So, and for example, this patient, she had a marriage 2 days ahead. Her marriage was 2 days ahead, and in India, there's a tradition of putting up a vermilion in Bihar from nose to forehead. So she wanted a quick fix for that. So I proposed a surgery, but I cannot do it. I cannot quick fix it. Just before her marriage. So I did her liquid rhinoplasty for her, and she was very happy. So a surgeon has a responsibility, or a facial aesthetic surgeon has a responsibility. Should have all kinds of armamentarium. You should know all the procedures. Should have everything in a basket, and use the best tool, whatever suits your patient. Because after all, it's your patient's choice and his satisfaction which matters most, right? And always believe in quality. I will say quality, quality, quality. Why? Because once you use quality equipment, quality products, quality trainings, you're bound to give a very good results. So thank you so much for your kind listening. With this, I end my talk over here. If anybody has any questions, they can connect me through WhatsApp or my email. And really sorry for the disturbance, as I just came home right now, so I couldn't go to my place from where.
Significant and best worldwide scientific over 23 and 24. Next. And continue to be up till now in the same rank. Please next. I cannot shift from my screen. Next.
Okay, next slide.
Yes. Next. I cannot shift from my screen.
No, doctor.
Obstructive sleep apnea since many thousand years, it's already under study, even during the pharaohs, they study it. Next. Well, why we treat obstructive sleep apnea? Because it can cause hypertension, carotid arteriosclerosis, stroke, pulmonary hypertension, nocturnal exacerbation of asthma. Next. Even it can lead to death. That's why we must treat this obstructive sleep apnea. Please next. Even this patient can be have sudden cardiac death at the morning. Next. And you must take care of the anesthesia. Also, there is a new effect of obstructive apnea that I have published before, that it can lead to stunted growth. So if you have a small child and all the children are less lens, you can do obstructive apnea surgery to get lens for them. Next. This occurs through insulin growth factor number 1. Next. How we will evaluate obstructive sleep apnea? We do history, examination, sleep study, and endoscopic evaluation. Firstly, by history. Next. By history, we will take the history from the patient to see if he have sleep-timed dizziness, affection, and if he have snoring and sleep apnea during sleep. Next. The most important score. Next, please. We will check by partner if there is obstructive sleep apnea or not, and we must get this score. Yes, next, please. The score is Epworth sleepiness score. You must ask the patient. Next, you must ask the patient if you get sleepiness during watching the TV. Leave next. If you get sleepy during car driving, if you get any car accident, and you will get the score from this 8 subject. After that, you will get the total score. Next. All this situation, you will ask the patient about. Next. And you will get the score. If you get score more than 10, so the patient has obstructive sleep apnea. If less than 10, no, he didn't have. The second one, next. The second one is examination. What we will do for examination? Next. We will do first Malabati score. Malabati, patient get the tongue out. While they get the tongue out, he opens his mouth and take quiet breathing. If you can see all the mouth and the pillar, this Malabati 1. If you cannot see all the pillar, this Malabati 2. If you cannot see the pillar at all, so you see all the soft palate, this Malabati 3. If you cannot see except the hard palate, this Malabati 4. But as you see here, this Malabati while the tongue is outside the mouth. This is not the normal sleep. Next. That's why it was being modified by Friedman's palate position, and this Friedman, the tongue is inside. And at this situation, the same, if you see all the pillar, it's 1. If you see only part of the pillar, it's 2. If you cannot see uvula at all, it's 3. If you cannot see except the hard palate, it's 4. Next. In patient who have, next please. If in patient who have T. Friedman or Malabati 4 or 3, we will go to surgery. What about the second thing is the tonsil size. We will see if the tonsil is embedded in the bed, it's 1. Just outside, it's 2. Behind large tonsil, but not touching its other, it's 3. If touching its other, so it's 4. And T4 and T3 need surgery to correct the sleep apnea. Next. As we said, T3 to 4 need tonsillectomy to correct the apnea. You must also examine the nose, searching for any polypi, any turbinate hypertrophy, and also you must examine the larynx and search for the epiglottic collapse as a main cause. Next. Then we will go to the sleep study. So we take history to examination, and now we'll go to the sleep study, polysomnography. Next. Polysomnography, we will see the type. The most important in polysomnography to know which is the type of obstructive sleep apnea. As we see here, is this normal breathing, airflow, and there is also respiratory movement at the mean time. But if no airflow and no respiratory movement, this is a central type of sleep apnea. But if you have no airflow, but you have respiratory movement, even excess respiratory movement, this will be called the obstructive type. If you have mixed, this is a mixed type. So you must know the type. If central, no respiratory movement, no respiratory flow, or obstructive, no respiratory airflow, but there is respiratory movement. Next. The second thing, as you see, this is the actual, this absent respiratory flow and absent movement. So it's central. But at the same, at other type, you see absent, but with action, so it's obstructive. Next. If you find what we will do for that patient, if you find central apnea, we have no rule of surgery. If we find central apnea, we will go to the CPAP or BiPAP. So it will be treated by pulmonary doctor, the chest doctor. So if it's no respiratory movement during respiratory, absent respiratory flow, this is not our patient as ENT. This will go to CPAP or BiPAP. Second, next. But if we have obstructive sleep apnea, we will check. If this patient obstructive or next less than century, I will check if this moderate and severe apnea, we can do surgery or CPAP. But if it's mild, next please. If it's mild apnea, we have no rule of CPAP, we have only surgery. So in mild apnea, we will go to surgery. In moderate and severe, we will go surgery or CPAP. Next. What's the severity? How to know the severity? If no obstructive sleep apnea, if apnea hypopnea index per hour is less than 5. Next. And it's mild if 5 to 10, 15, and moderate if 15 to 30. And as we usually tell, if more than 50 per hour, this means that we have multi-level obstruction. Next. We do all the treatment. We can do the polysomnography by the EEG also, but we can do also polygrammetry only without the EEG, as we do in multiple of our study. Next. How we treat obstructive sleep apnea? Firstly, you must do this measure. You must reduce weight. You must decrease drug and alcohol. You must stop smoking. You must do postural training during sleep on one side. Nasal metancy, cake and steroid. And then if this result no effect, we can go to CPAP or surgery. Next. CPAP depend on to open the airway by air. Pushing air, so the obstructed area will be blocked, will be opened by the air. So CPAP depend also on expansion. Its rule is expansion. Next. This expansion will open this obstructed area. Next. So the idea is expansion of the airway using the airflow, power of airflow. Next. 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 But CPAP mask could be over the nose only, over the nose and mouth, or over the mouth only. So nasal or nasal mask or nasal pillow. Next. But CPAP has many problems. The most important problem is poor compliance. More than 40% of the patient cannot complain and cannot tolerate. Also many side effects because of the high power of air. Next. We need also regular maintenance and regular follow-up. Next. Next. And there is many contraindications for CPAP. The most important for us as ENT is to check if the patient have epiglottic collapse or not. If the patient has epiglottic collapse, he will exaggerate its obstructive apnea by CPAP. So CPAP will exaggerate the problem, not decrease it. Next, so they must try to check for epiglottic sleep apnea. Then the second thing is the nasoendoscopy. We do nasoendoscopy awake with molar moreover or during sleep by drug-induced sleep endoscopy. Next, what we will benefit from this nasoendoscopy. Next, please. Nasoendoscopy, next, will give us which treatment we'll go through. This treatment at the area of retroglossal or at the area of retropalatal. Always the failure comes from retroglossal defect. Next. So, if you get obstructive sleep apnea, now how we will treat that patient? If you get obstructive sleep apnea with a static obstruction, like large tonsil, T3 or T4, we will go to tonsillectomy. Large adenoid, we will go to adenectomy. Nasal polyp, we will remove. Tongue-based lymphoid tissue, we will do reduction for it. So if there is static obstruction, not collapsible area, we will try to remove it. Next. Static obstruction, remove. But if there is dynamic obstruction, collapse, if there is a lateral pharyngeal rule and palate, we will do expansion and stabilization by one of these procedures. Next. The last thing is to do maxillomandibular advancement if the other treatment failed. Next. How we choose our treatment. at the level of the retropalatal area and at the level of retroglossal area. We will begin by retropalatal area. Next. The most procedures are to expand this area over the velopharyngeal area. So what we will do, we will do expansion and stabilization, not removal. Not removal. You will preserve the mucosa. Again, next. By minimally invasive maneuver, Kahali begins this procedure on 23, and he described lateral pharyngoplasty. Then Watson described expansion sphincter pharyngoplasty, and the Bank described the modification of that. Next. And we come on 2018, do the suspension suture that much less simple and less and more effective than both procedure. Next. What's the suspension suture that we already published in the American Academy 2016? Next. So if we have retropalatal collapse by nasoendoscopy, lateral collapse only, we will do suspension suture. Anterolateral collapse, we will do modified anterior palatoplasty. Both collapse, lateral and endomod, this is a modified palatoplasty. Both lateral and circular, we will do both. The suspension suture and the modified palatoplasty. Next. Suspension suture is an easy, we published it in 2016 and republished another large study on 2018. And as we see here, we will not do like done before by Bank to do expansion pharyngoplasty, removing the palatoglossal muscle and expand it. What's a difficult procedure. We will only depend on suturing. Next. So we will do suturing without removing of the palatoglossal muscle and distracting it. Do the suture to the palatoglossal muscle, palatopharyngeal muscle, and taking it to pterygoid humulus behind by suspension suture. Next. How we do the suture? We first identify the pterygoid humulus. Next. After identification of the pterygoid humulus, we can take the palatopharyngeal. Next. The palatopharyngeal muscle, take it from the posterior pillar and catching it without cutting, so it will be with us. Then go to the behind the palato, the pterygoid humulus. Next. Now we are behind the pterygoid humulus. It's easy to identify, just to put the retractor here. Next. Then we will return again, taking the palatoglossal muscle. Next. So now we can tighten the suture coming out by the palatoglossal muscle within the bed. So tighten the suture within the bed, not appear behind. Next. And at this time, we will come again palatopharyngeal muscle, and now we can suture it, and we can see now how it's expanding the area without cutting. Expanding the area is not done, and expanding anteroinferior widens this area before cutting. Next. And as we said before, we published it in the American Academy 2016. Next. And also describe it in the European Academy. Next. As a new simple procedure. Described it in the European Academy also. Next. And we republished it in the Clinical Otorhinolaryngology in England as a large sample of paper on patient. Next. As we see here, we exceed also, we can do double suspension suture, taking the middle also to the temporomandibular raphe, so we can expand it. But if you do this procedure, you must do tonsillectomy also, because you will close the bed here. And also we publish it on 2018. Next. How we do the anterior modified palatoplasty. Modified palatoplasty, you take rectangular area from here, removal of some mucosa and submucosa, not remove the muscle, leave the levator palatine, and remove the edge of the palate. Then close it in mattress suture. And as we see here, we expand this area anterior and getting the uvula and the retropalatal space opened. Next. This also was published by us in 2018 as a main procedure for the central collapse. Next. And you must take care that you must keep here at least 2.5 centimeters to prevent velopharyngeal incompetence, as we published before. Next. So keep here 2.5 centimeter. Next. What about retroglossal area? And this is the most common cause of failure. What's the diagram or algorithm to treat this area? Next. If the nasal endoscopy, next please. If the nasal endoscopy give us, we will see the algorithm here, and we will publish that algorithm already in Craniofacial Journal. Next, please. If you do the tongue base, if the nasal endoscopy appear anteroposterior collapse like that, and the high collapse, so lymph reduction will be done. But if low collapse, we will do genioglossus advancement. So if anteroposterior and high collapse, lymph node reduction. If low, genioglossus advancement. But if the obstruction at lateral obstruction like that, not anteroposterior, we will do for at this side, next please, hyoid suspension. So if lateral, the maneuver is hyoid suspension. Next please. And this is the diagram, and it's very important diagram and algorithm to treat the obstructive sleep apnea at the retrolingual space. And we advise all to catch this diagram and keep it with them. Next. Take care, epiglottic collapse cannot be treated by CPAP, to only treated by supraglottoplexy. Next. We can do multi-level surgery at the same time to the retropalatal and at the same time to the hyoid suspension, and we publish many papers in this level, hyoid suspension with the retropalatal suspension suture. This is because the suspension suture is not a difficult procedure. Next. Many papers on this side we do for hyoid suspension with the suspension suture. Next. We publish over the years of many cases and many papers. Next. It's the most important procedure in hyoid suspension, and we advise all to learn it and train on it, is the expansion hyodothyroidopexy. To cut the hyoid bone in the middle, make a hole at the end and each side after identification of it, then catch it on each side to the thyroid cartilage and fix. And this goes all in one procedure. Everything for hyoid can be achieved, and we already get published this paper in American Academy. Next. Nasal surgery is very helpful for snoring, but it's not so important for obstructive apnea. And always take care. No obstructive sleep apnea treated by nasal surgery alone. Nasal surgery alone could treat snoring, but could not treat obstructive sleep apnea only. Okay, next. The most important again to choose the treatment. We can summarize the choose the treatment. Next. How we choose? We will do a sleep study. If the central apnea, we will go to CPAP. So next, please. If central apnea, we will not do surgery, only CPAP. Okay. Next. If obstructive sleep apnea and retropalatal level, if this lateral collapse, we will do suspension suture only. If anteroposterior collapse, we will do modified anterior palatoplasty. If circular, we will do both suspension suture and modified anterior palatoplasty. Next. But if tongue base obstructive sleep apnea, retroglossal, we will check if central collapse and high with lymphoid tissue, we will remove. No lymphoid tissue, we will do genioglossus advancement. If low, we will do tongue base reduction. But if lateral collapse, not central, or on both sides, we will go to hyoid suspension. And this algorithm, first one and second one, is the idea and the main to take the decision which surgery will choose. Next. How to tell that your patient has responded to surgery or not? If the patient get more than 50% reduction of preoperative apnea hypopnea index, is complete success. And if the patient less than 50% from preoperative, it's a failure. If no increase in the preoperative risk as single or multiple level surgery, no difference. So your aim is to get more than 50% reduction of preoperative apnea hypopnea index, or get less than 20 apnea hypopnea index per hour. Next. Uvula is very important. Keep uvula. Don't remove the uvula. uvula is very important. It is important to get the serous secretion. And if you remove the uvula, the patient will always complain of getting thick secretion and sticky secretion in the throat. So don't remove the uvula. You can do uvuloplasty, but don't remove. Next. Modified, the most important thing that occur after U3B. I didn't do U3B, and U3B you must not do. The most problem in UVB3B is to get nasopharyngeal stenosis, and this is a very difficult condition to treat. We do modified zeblasty to repair, but it is very difficult procedure and very difficult to treat. Please try to not do U3B. Next. The last thing is that you can, to avoid the obstructive sleep apnea, if you cannot solve, you can do tracheostomy to bypass all the obstruction above. Next, this is our reference with our team for obstructive sleep apnea. We have many references on that on our procedure as a new and multiple modified procedure, and we are ready to help anyone in this procedure, inshallah. Next. Thank you, and I am ready for any question. Finish. Thank you.
So thank you so much, Dr. Mohammed Wahid.
Thank you.
So any question from the audience?
Next, please. Hello? Yeah. So as you know, the hearing aid is very important for the patient in order to be able to communicate freely, especially in the elderly, and the need for keeping the indication is very important as practicing to be a good practice as ENT or the hearing instrument specialist or healthcare provider. Next, please. So most of the patient will, no, previous slide, please, kindly, you skip one. So most of the patient will be unable to explain their needs or unable to communicate and or to bother from the noise situation. Usually they say, I could hear fine if my spouse wasn't always talking to me from the other room. So usually the other room will be the far away, they can't hear. So, or they can hear, but they just can't understand. So there's like the words, they can't understand the words. Or I hear fine, but it's just that people is like the sound is mumping or dropping their voice or covering their mouth when they speak, they can't recognize. Next, please. There is 31 million Canadian who have some degree of hearing loss, and this is a graph showing the increasing number from 1989 to the next years followed. Next, please. So 80% of the adults with hearing loss can be helped if the problem is diagnosed and the right time. The patient will be unable to recognize that he having hearing loss during to his age maybe, and he will denial in the first stage of having hearing loss, and most of them will refuse to wear hearing aid. The overall customer satisfaction with the new hearing aid is only 77%, according to the statistics, and placing hearing aids in the top third of the products and services in the United States. Gathering information is an important first step in the recognition of the patient and the indication. Next, please. So how we hear, as you know, next, please. There is outer ear and middle ear and inner ear. This structure will be diagnosed according to the audiometry and the temporometry. Next, please. So the outer ear catches the sound waves and directs it to the ear canal. The ear canal carries the sound waves to the eardrum, tympanic membrane. The sound waves causes the eardrum to be vibrating, and then the three small bones in the middle ear pick up the vibration. The vibration transfer to cochlea and then the hearing through the nerve, the hearing nerve. Next, please. Next, please. So the types of hearing is conductive or sensorineural or mixed or central loose. Next, please. The sound is blocked in the first case or turned down as it moves through the outer and middle ear. Typically treated with medicine or surgery, especially if there is any like otosclerosis or any middle ear problem. The hearing aids is a second, the remaining option. Next, please. In sensorineural hearing loss, the inner ear cannot send sound correctly to the brain and typically treated with hearing aid. Next, please. In mixed hearing loss, the contribution of both conductive and sensorineural, typically treated with medicine or surgery, plus hearing aid and as option. Next, please. In the central hearing loss, auditory nerve cannot send signals to the brain, or brain cannot receive signals correctly. Assistive listening device is indicated here. Next, please. The audiogram is an essential step in planning for the hearing aid, and it measures the ability to hear sounds. As you know, pitch is the frequency and loudness is the intensity, as shown in the graph on the left side. We should identify the types of the hearing loss, conductive or sensorineural or mixed, and the range and the low frequency, mid frequency or high frequency, the degree mild or moderate or severe to profound hearing loss. Next, please. Hearing loss can range from low pitch to high pitch. In the low frequency, there is the vowels, and in the high frequency, consonants. Next, please. Then we decide the degree of the hearing loss according to the schedule. Next, please. As normal or mild or moderate or severe or profound hearing loss. Next, please. After that, we decide the hearing aid and the fitting and how to do the rest of applying the hearing aid. We verify the hearing aid style according to the patient wishes and to his audiometry. We can connect from CIC complete in the canal, or ITC in the canal, or ITE in the ear, or behind the ear, or open behind the ear with the open fit. Next, please. Here is the CIC as shown in the picture, and it's indicated in mild to moderate severe hearing loss. Next, please. Here's a picture in the canal, and it's indicated on some mild to moderate severe hearing loss. Next, please. Here in the ear, and the mold is helpful here, but we should take care if the patient especially has post-cholesteatoma to take care of the way to have drainage and to have good aeration for the ear. So this is indicated in mild to severe hearing loss. Next, please. And the behind the ear is very good advantages that it has good charger, especially for kids. It can stand for more than 22 hours. The problem of it that it's bulky, it's fixed in the behind the ear, but it's very good for a mild to profound hearing loss. Next, please. The open behind the ear is nowadays the most common that is being used due to it's like very good in cosmetic and in aeration. Yeah, and it's very suitable for mild to severe hearing loss. So there's impact in unilateral hearing loss, and that you feel the impact that you feel isolation from the society, from family and friends, and it's embarrassing, and it's decreasing the job performance, even the earning the power. As it worsens, hearing loss can cause people to become depressed or fearful and anxious and angry and frustrated, even suicide. Next, please. The benefit of amplification and verification and using the ANLI and NLIS, and this is very painful benefit for the patient to be able to understand the words, to be communicated with the words correctly with their families. And this will help them to better self-esteem and improve mental health, especially in elderly, and create independence and security. Next, please. So the first step, usually in Canada, they used to go to the hearing instrument specialist or the hearing instrument dispenser, who will be seeing them in the clinic, which is provided away from the hospitals or in the hospitals, and they will be able to have audiometry, temporometry, and then the request be sent to the general practitioner or to ENT in order to have their signature and approval for the insurance to be provide the hearing aid. So hearing aid can't be sold in Canada through the independence without like medical advice and without prescription. And there is all the companies that selling hearing aids are in competitive, and the patient will be selecting his hearing aid according to his needs. Next, please. So we, as you know, the stages of the hearing aid, how it works. So through microphone and then amplifier, then the receiver. And this is varied according to the frequency that the each hearing aid is using, and the company keeping their ships in a like secret and demanding and very secure. Still, there is a lot of competition between them and the like sound quality and regarding the safety. And now even the AI is being entered to this industry, which is improving the connectivity of the patient with the environment, especially if they have like the technology, the new technology and new mobile is available nowadays. Next, please. This is the end, and thanks for your listening. Thank you.
Osteoma is a benign tumor belonging to the group of osteogenic tumors. They are localized mainly in the projection of the drum-scaly suture of the external auditory canal. Here you can see a clinical manifestation such as conductive hearing loss, ear noise, and otitis externa. In some cases, dizziness, sensory neural hearing loss, and trigeminal neuralgia were observed. Located outward from the bone, osteomas on the X-ray have the appearance of a spherical bone formation. Macroscopically, the tumor is visualized as a rounded formation. Here, histological structures of osteoma are presented. Visually, exostosis and osteomas are the same. Here, histological structure of exostosis is presented. According to study, the surgical removal is the only method of treatment. Yet, the high risk of intraoperative injury of the tympanic membrane, auditory ossicle, and facial nerve remains. Most sources provided information on the technique of surgical removal when describing isolated cases of osteoma and exostosis of the when a postoperative complication occurs. The purpose of our work is to compare the results of surgical treatment of osteoma of the external auditory canal using endoral or retroauricular approaches. Research materials and methods. 24 patients with bone tumors were examined in clinic number 3 in Krasnodar city. Out of them, 19 had the removal of tumor with retroauricular access. Criteria for the effectiveness of treatment were absence of recurrence in the long-term period, restoration of patency of the external auditory canal, absence of postoperative complication. The observation period is 7 years. Assessment of the quality of life is based on a questionnaire of GBI. Multiple formation and single formation were removed with the usage of various surgical approaches. Stage of the surgery are presented here. Results. Patients were at the control examination in the long-term period for 3, 5, and 7 years after the surgery. The effectiveness of surgical bone tumors removed was approved endoscopically and with help of audiometrical examination. Conclusion. The choice of surgical approach depends on bone tumor localization and its amount. Thank you for your attention. Have good time.
So that was an excellent presentation by Ms. Urena. Is there any question?
Expression we express. What is an aesthetic smile? It is a gingival display between the inferior border of the upper lip and the margin of the maxillary anterior teeth when it is 1 to 2 millimeter. However, there can be certain instances when the smile might not be pleasant and have some complications. For example, a gummy smile. Now, a gummy smile can have either a functional limitations or psychological discomfort, social discomfort. The most important part is an appropriate diagnosis and a treatment plan. The treatment plan can have surgical or non-surgical therapy, lip lengthening technique, orthodontic or orthognathic surgery, and lip repositioning surgery. It can have either dental causes or non-dental causes. The etiology can be altered passive eruption, gingival enlargement, short clinical crown, dentoalveolar compensation, a high smile line, a short upper lip, hyperactive upper lip, vertical maxillary excess, or a combination of these. The diagnosis is the most essential factor. So now when we diagnose, we have to consider certain factors. For example, if there is an increased incisor exposure during rest or a normal incisor exposure during rest. If there is an increased incisor exposure during rest, the patient might have a normal lip length or a short lip length. In case of a normal lip length, there might be a difference between anterior and posterior occlusal planes, which can cause incisor over eruption, or a harmonious occlusal plane, which might be due to vertical maxillary excess. In case of a normal incisor exposure during rest, there might be a short clinical crown or a normal clinical crown. A short clinical crown can be due to incisor atresion, which causes incisor over eruption, which is a compensatory mechanism, or when there is no atresion, which can be due to altered passive eruption or gingival enlargement. A normal clinical crown can be due to a hyperactive upper lip. Coming to the steps of a diagnosis, the most important is to analyze the facial proportions in case of a gummy smile, or the amount of gingival display, and a radiographic examination. Vertical maxillary excess is when we divide the face into 3 equal parts from the hairline to the glabella, subnasale, and menton, and they should be in the ratio of 1:1:1. Furthermore, the lower third of the face has to be in the ratio of 1:1:1. Now, coming to the smile line evaluation, when we check the smile line from the upper lip to the incisal part of the tooth, it has to be in proportion. So a high smile line is when the total cervico-incisal length of the maxillary teeth is continuous, and it shows a continuous band of gingiva. An average smile shows 75 to 100% of the teeth and the interproximal gingiva only. And a low smile displaces only the incisal part of the teeth. Now we must measure the lip length to see the reason of the gummy smile. Now in this photo, we can see the measurement is 15 millimeter, which shows a short upper lip and causes a hyperactive upper lip. Now, what is a hyperactive upper lip? It is when there is an excessive contraction of the elevators of the upper lip, and the apical movement of the upper lip is more than 8 millimeter. In this photo, it is more than 9 millimeter, which indicates a hyperactive upper lip. When we perform a surgery, the gingival margin, outline, and zenith are very important to showcase a proper aesthetic smile. Now, in this photo, we can see when we draw an imaginary line joining the papillary tips of the maxillary anterior teeth. Now, this line has to be parallel to both the incisal edge of the maxillary teeth and the curvature of the lower lip. And the zenith, as we can see in this photo, the lateral incisor zenith coincides with the line from the straight line, and the zenith of the central incisor and canine has to be slightly distal to the long axis. Once achieved, it is a perfect blend of white and pink. The treatment of a gummy smile can be as simple as a botulinum toxin, or it can be a lip repositioning surgery. Now in this, we can see the pre-op and post-op image. We can see the clear difference in it, and this can be achieved after a surgery. Another case for a short clinical crown, the reason might be severe atresia, which is dentoalveolar compensation or altered passive eruption. There can also be, now let us understand what altered passive eruption is first. So altered passive eruption is a condition when the gingival margin fails to migrate apically to the level of the cemento-enamel junction, and it occurs after the complete eruption of active eruption. Now, because the gingival tissues are positioned coronal to the cemento-enamel junction, they appear short and square. There can also be situations when there is a combination of conditions, for example, altered passive eruption alone or a hypermobile upper lip alone or a combination of both of them. Altered passive eruption, we can see this is an active eruption when the crown moves in a coronal direction and contacts the opposing teeth and occludes them. A passive eruption is the apical movement of the gingival margin to the level of cemento-enamel junction after the tooth has achieved active eruption. There are different stages for a passive eruption. Let us understand it by this video. So in this video, active and passive eruption are explained properly. When the teeth move to the level of occlusion, they reach the opposing teeth and contact them. Now this is called as active eruption, when the teeth move in coronal direction and contacts the opposing teeth. When the gums recede to the apical direction after the completion of active eruption, it is called as passive eruption. So we can see the gums are moving in an apical direction and complete exposure of the teeth is visible. Now, when the gums fail to recede back to the cemento-enamel junction, it is known as a condition called as altered passive eruption, which gives the teeth a short and square appearance, and then it looks to be a gummy smile. This is when biological width comes into consideration. So biological width is something that is the relation of the soft tissue to the bone, and it should be maintained at a constant level of 2.04 millimeter. So Coslet et al. In 1977 gave a classification for altered passive eruption. Let us understand it. So Coslet type 1 subgroup A is when there is adequate amount of attached gingiva and the osseous crest is 2 to 3 millimeter apical to the cemento-enamel junction. The gingival margin is incisal to the CJ. In this condition, the treatment is gingivectomy. Coslet type 1 subgroup B is when there is adequate amount of attached gingiva, the osseous crest is at CEJ and gingival margin is incisal to the CEJ. Then the treatment is gingivectomy and osseous recontouring. Coslet type 2 subgroup A is when there is inadequate amount of attached gingiva, the osseous crest is 2 to 3 millimeter apical to the cemento-enamel junction and the gingival margin is incisal to the CEJ. The treatment is apically positioned flap. And when there is inadequate amount of attached gingiva, osseous crest is at the CJ and gingival margin is incisal to the CJ. The treatment is apically positioned flap with osseous recontouring. Now let us see this case report. So a 24-year-old female patient reported to the department with a gummy smile. She did not have any other complaints. On extraoral examination, her facial proportions were normal. Her face was apparently bilaterally symmetrical. Her lip length was 20 mm. We evaluated her smile. She had a high smile line and a hyperactive upper lip. As we can see, it is 9 millimeter. The intraoral examination showed excessive gingival display, short and squarish looking teeth, and there was adequate amount of keratinized tissue. So we examined her teeth. After adequate probing, we saw that there was no biological width. The biological width was inadequate. The radiograph also showed the cemento-enamel junction and the bone margin at the same level. So coming to our diagnosis, it is altered passive eruption, Coslet 1 type B with a hyperactive upper lip. So our treatment plan was gingivectomy with osseous reduction and injection of botulinum toxin. After explaining the patient and a consent, we started our surgical procedure. The bleeding points were marked and gingivectomy was done. So we can also perform gingivectomy with the help of a choose gauge. So now this gauge has proper markings, and we have to keep it on the tooth and coincide the color codes. So it shows the adequate proportion of the crown ratio. We use this for gingivectomy. Then we reflected a flap, and we could see the bone clearly. The bone showed that the osseous crest and the cemento-enamel junction are at the same level. Then we achieved a biological width using our instruments, hand instruments, and biological width was established. After that, we placed the flap at the position because gingivectomy was already done and sutured it. Now this was our post-op results. As we can see, the pre and post-op, there was a clear image, clear difference is seen, and after this, botulinum toxin was injected. So this is how we can achieve a perfect smile by the appropriate diagnosis and treatment plan. So concluding, excessive gingival display is a great aesthetic concern, and appropriate diagnosis is crucial to achieve the best results while approaching a case of gummy smile. Thank you so much.
Or more accurately, color vision deficiency. This condition affects millions of people worldwide, making it difficult for them to distinguish between certain colors in this presentation. I will cover the prevalence of color blindness, the types, the genetic causes, and how it affects the vision, and how we will cure it by using sunglasses. Before I start my presentation, I would like to introduce myself within a second. I'm the very first person in Bangladesh who developed colorblind glass in my own way. And this is the cheapest colorblind glass in the world. And I have a two feature in my glasses, which is not available in the world. I can adjust eyesight power who have a problem in eye power. And you know what is sunglasses? When you put sunglasses on your eyes, from the outside, the people, they cannot see your eyes. And people who are suffering from the color blindness, they are actually facing in problem in medical board. The medical officer do not allow any sunglasses to do face any medical exam. But about my glasses, if you put my glass on your eyes, outside from the people can see your eyes. So this is the difference, my glasses from the Enchroma or Pylestone. Okay, please move on the next slide. Hello, fine. So now the question is, what is color blindness? People when hear about the word of color blindness, or sometimes when people hear who he is colorblind or she is colorblind, they start thinking like they cannot see any colors. But this is a total misconception of everyone. Like me, I'm the colorblind person. I can see the every colors, but sometimes I cannot distinguish some colors. For me, I can distinguish red and green in together. Okay, so what is color blindness? Color blindness is not complete blindness to color, but rather reduced ability to distinguish certain colors, particularly reds and greens. People with color blindness see the world differently, and it may impact their daily lives in subtle ways. As the slide points out, 1 in 12 men and 1 in 200 women are affected by some form of color blindness. This significant difference in prevalence is due to genetic nature of the condition, which I will explain later. Please move on the next slide. Types of color blindness. Red and green color blindness is the most common type of color blindness. Color blindness is mostly common categorized as red-green color blindness, but there are other types too. Let's take a close look at the types mentioned on the slide. Please go back the next slide, before previous slide. Okay. Let's take a closer look at the types mentioned on the slide. Due to anomaly, this is the most common type. People with this condition have a hard time distinguishing green shades. Protonomaly, a reduced sensitivity to red light. People often confuse reds with greens or browns. Protanopia, this is more severe, where reds appear as dark shades and individuals cannot differentiate between red and green at all. Deuteranopia, similar to protanopia but affects green perception more severely. Greens appear as dull shades. In all these cases, people still see colors, but it in a different range or shade than those with normal vision. Go for next slide. So causes of color blindness. Did you know why? Now let's explore what causes color blindness. Genetic mutation. As the slide mentions, color blindness is often caused by a genetic mutation linked to the X chromosome. It is an X-linked recessive condition, meaning it is more common in males because they have only one X chromosome. Women, on the other hand, need 2 copies of the defective gene to be colorblind, which is why fewer women are affected in the world. Next slide, please. Sorry, can you go in previous slide? Please go to previous slide. Notice I'm saying previous. Go back to previous slide, please. Previous. Previous. Back to one more slide. One more. Hold here. Okay, now I am going to talk about rod and cone cells. Our eyes contains special cells called rod cells and cones. Rod helps us see in low light, meaning rod cell helps us to see the white and black color. Cones are responsible for detecting colors. Actually, cones are helping us to see all the color in the world. People with normal vision have 3 types of cone cells detected: red, green, and blue light. In color blindness, one or more types of cone cells either do not function properly or are absent, causing difficulty in perceiving certain colors. Please go for next slide. Okay, can you see this number? This is the very interesting thing. People who are not seeing this number, I'm very sorry to say you are colorblind like me. This is the Ishihara plate. We diagnose a colorblind patient by giving Ishihara plate. Who are unable to see this number or read this number, we detected or we consider as a colorblind person. Go for next slide. Whatever this number, I hope you all are seeing this number, but who are not, I'm sorry for you. Next for. Next to move slide. Next move to next slide, please. Try this then. This is the final Ishihara plate from my slides. I hope you all are seeing these numbers. Okay. Move on the next slide. Okay, I took this table from my research paper. I did a research in my country among 122 people. I choose them randomly and give them Ishihara plate. I got 10 people from 122 people who are detected as colorblind. And after getting them, I give my own colorblind glass to check their improvement. And if I talk about number 1 participant, he was able to see only 0.6 plate from 38 Ishihara plate. After wiring my glass, he was able to see 32 plates from 38 Ishihara plates. For the number 2 participant, he was able to see only 0.4 plates without glass from the 38 Ishihara plates. After wiring my glass, he was able to see 34 plates from 38 Ishihara plates. This is the table. Okay, I'm going to talk about the last participant, which one is 10. He was able to read only 0.05 plate from 38, and after wiring my glass, he was able to see most of the Ishihara plates. It was 33, and his improvement was 74%. Next slide, please. This is the very interesting slide. People who are colorblind and who are not, how they are seeing the world. I'm trying to present it. See, I divide apple in 2 ways. One division is full color, who is not colorblind. They are seeing the apple like this, and who are the colorblind person, they are see the apple this way like me. And I took a picture from a fruit zone. See, people who are not colorblind, they are seeing the everything colorful in fruit zone, or who are colorblind, they may see the world like this. And colorblindness can affect daily activities such as driving difficulty, distinguish traffic lights or brake lights, reading information, challenges in understanding color, code, charts, maps, or graphs. Career choice, some careers such as pilots, like me, it was my childhood dream to be a pilot. Forget it. Electricians and graphic designer require accurate color perception, which can be a limitation for colorblind individual. However, people with colorblindness often adapt well. They may rely on a brightness or position rather than color to interpret visual information. Or people who are colorblind, they can use my glasses to see the world colorful and see the color with vibe. Coloring glass, actually special glasses with tinted lens, can help enhance color perception by filtering out certain wavelengths of light. These are not perfect but can be helpful in some situations. In summary, colorblindness is a condition that affects a significant number of people. While it poses changes, those affected often adapt remarkable well. Understanding color blindness helps foster inclusivity and empathy, especially in designing color-coded system, learning materials, and even everyday interactions. Thank you for your attention. I would be happy to answer any question you might have. That is all from me.
So thank you so much, Dr. Saifuddin, for the presentation. So any question?
Concise and short as much as I can. So this is my study, our retrospective study on the rare tumor on the head region, which is neurogenic tumors. So we conducted in this study at National Cancer Institute of Egypt. And here is our objective: to describe the neurogenic head and neck tumor, outline the anatomy of the parapharyngeal space and the study aim and the methodology, result discussion and the conclusion and take-home message. So let's start with background first. As we all know, that lateral neck mass management frequently challenges surgeon because the presence of this such a tumor near important structure in the neck, like carotid vessels or vagus nerve or phrenic nerve or trachea or esophagus itself. So it's really challenging to us, or even it may be near to the base of skull, vertebral column. So a lot of challenge confront surgeon usually. And also rarity of such a tumor, so it wouldn't be in the first differential diagnosis in our mind when we see such a patient. So the head and neck region is by far the most common location for such neurogenic tumor, and they form a very small percentage of all neoplastic lesions of the head and neck region. Although these tumors are considered under the major heading of soft tissue tumor, but there, as I said, the unique presentation and the systemic workup and imaging study necessary for accurate diagnosis to facilitate treatment plan. Imagine if you approaching a patient with such a tumor because you know your differential diagnosis, or you suspect it's like usual soft tissue tumor, and you discovered it is paraganglioma or carotid body tumor and a lot of hemorrhage around when you take a biopsy or during interoperative. That's why I would like to discuss our study with you today. So definition and the classification, they arise from neural-crest derivative. We have a lot of entity or a lot of variety of neurologic tumor. First one on which is peripheral nerve tumor, and under it a lot of tumors also, benign and malignant, such as benign tumors as mucosal neuroma, schwannoma, neurofibroma, dermal nerve sheath myxoma, and gynecological tumor. Malignant tumors including malignant peripheral nerve sheath tumor, malignant schwannoma, neurofibromosarcoma, and malignant peripheral nerve sheath tumor. Autonomic nerve tumor, plexusarcoma. Paraganglioma are tumor of paragangliomic tissue. They are composed of neuroendocrine tissue. They are rare neuroendocrine neoplasm, under which also carotid body tumor. Neuroplastic tumor, most exclusively in childhood period, like neuroblastoma, ganglioneuroblastoma, and ganglioneuroma. And lastly, olfactory neoblastoma. Olfactory neoblastoma are malignant to neoplasm thought to arise from specialized sensory neuroepithelia or neuroectodermal olfactory cell by Bura neurons normally found in the upper part of nasal cavity. So our management strategy, our approaching, when we approach such patient, we should, first step, we should do proper diagnosis, and identify nerve of origin is a true challenge. Because we don't a lot of nerves at the head and neck, and we don't know what is the nerve of origin. And if we can know the nerve of origin, it will facilitate a discussion with the patient about possible or potential comorbidities or nerve palsy, functional disability. Treatment strategies depend on the site and the site of the tumor, post-surgical functional loss or not, patient age and profession, and the potential risk of cranial nerve palsy also. And unfortunately, these tumors are radio resistant, so radiation only. We give only radiation for patients who are as a palliative treatment or for metastatic patients only, unfortunately. So let's start with the anatomy of parapharyngeal space. As you know, the parapharyngeal space is inverted cone space. The base of this space is directed upward to the base of the skull, and the tip directed downward to the hyoid bone. Medial wall formed by parapharyngeal wall and the tonsillar fossa, and the lateral wall formed by parotid gland and the paravertebral muscle and the fascia. Here is the space. This is a parapharyngeal space, and a lot of nerves present in this area, which is the origin of such a tumor. As you see, imagine a lot of nerves here. So it is more common in the head and neck. Such a tumor, it is more common in the head and neck region. If you see, this is the percentage, or from literature, the percentage of the neurogenic head and neck tumor all over the body. As you see, the large percentage lie on the head and the neck region. So our aim of our study was, this was a retrospective study described, as I said, the International Cancer Institute 10 years experience with extracranial head and neck neurogenic tumor by presenting their clinical features, diagnostic method, radiological or biochemical, surgical decisions, and the treatment outcome, which is whether functional and oncological, overall survival, and disease-free survival outcome. Patient and method study site, as I said, it was in National Cancer Institute, Egypt, and the study type descriptive over 10 years. Inclusion criteria: this study include all patient group of all ages group who were diagnosed with extracranial head and neck tumor. Data collection from data collected from biostatistic department, which include socio-demographic data like age and sex, tumor characteristic type, grade, TNM staging, primary or recurrent, surgical parameter, both excisional loss or of nerve function. Statistical analysis: we collected 40 patients, or 40 patients were included in this study. Numerical data were identified using means and standard deviation or medians. and ranges as appropriate, and categorical data were summarized as numbers and percentages. Due to variety of neurogenic tumor of the head and neck, it was found after consulting medical statistic experts that the best method to describe such rare tumors is to use the methodology of descriptive epidemiology. Ethical issues. This study is retrospective, so no harm to the patient, and all data were collected anonymously. Result of the study. So patients' ages range from 2 to 78 years. Our mean was 34.7 years. Childhood neurogenic tumor accounted for 9 cases. Percentage was 99 only in this study. And presenting symptoms, the most common presenting symptom is neck lump. Other patient complaints were recurrence of an old lesion or neck pain as follows. Neck lump was 50% of patients, recurrence was 17% of patients, and nasal mass was 15, and so on. Little epistaxis was found in one patient, and it was due to olfactory neuroblastoma, as we will see later. And here is MRI finding of cervical schwannoma. So for imaging studies, the most common used investigation is computed tomography, CT scan, in 42.5% of patients. Then CT angiography, most exclusively in patients with paraganglioma, and ultrasound in 4 cases only. MRI in 4 cases only also, while no imaging study was requested in 6 cases, 15% of patients, especially in skin nodules or oral cavity lesion. And here is MRI showing cervical schwannoma, as I'm pointed to here, this mass. This is picture of CT angiography of carotid body tumor showing a Liar sign, which is displaying of the post carotid. Here is the carotid body tumor and displaying of post carotid. And here is MRI, and here is MRI of olfactory neuroblastoma. This is a mass. Starting to invade the base of the skull. Pathological pattern. 48% of patients were peripheral nerve tumors, most common tumor. Then the paraganglioma, and lastly, sympathetic chain tumor was only 7% only of patients. So in this study, benign cases to malignancy, benign cases were 45% of all of cases, then malignant cases 37, and unpredicted behavior was 17.5, mostly also from paraganglioma, because paraganglioma, as you know, and carotid body tumor are of unpredicted behavior, most of this tumor. Childhood tumor. For childhood tumor, childhood neurogenic tumor, mostly as which account for 9 cases, 22.5 only of this study. Most of them are neoplastic tumor and neurofibroma, 33% of each, as you see. And also we found 1 patient with carotid body tumor, and child patient with carotid body tumor, and 1 patient with olfactory neuroblastoma, and the last one with glial cell tumor. So our treatment was, and the follow-up, neoadjuvant chemotherapy treatment was received in 7 cases. In all cases of olfactory neuroblastoma, we have given neoadjuvant chemotherapy, and 1 case diagnosed with gangrene neuroblastoma. And the concomitant chemoradiation was used in patients with malignant peripheral nerve sheath tumor with intracranial extension. So it was unresectable, T4 and T3. So we tried with them concomitant chemoradiation. Surgical management, which was the main line of treatment, is a study conducted on all cases except 4 cases died when they were receiving neoadjuvant treatment. Type of surgery was wide local excision in 20 cases, and wide local excision and lymph node dissection in all paraganglioma cases, except 1 metastatic case at time of presentation. So we didn't do for them surgical excision. Minimal invasive surgery in 3 out of 6 cases of olfactory neuroblastoma, and partial maxillectomy through transfacial approach in 1 patient with olfactory neuroblastoma. Rest of olfactory neuroblastoma, which was 2 patients, received concomitant chemoradiotherapy, as I said, and the other one died while during the diagnosis. The most common site of metastatic spread were to lung and bone cervical lymph node in 5 cases, 4 of them due to malignant carotid body tumor, and 1 was due to olfactory neuroblastoma case. Okay. Post-operative adjuvant treatment was received in 8 cases post-operatively. Outcome. From the whole sample, complication had occurred in 13 cases, 32.5%, most of them during paraganglioma dissection, because it is the closest to a tumor to the important structure such as carotid vessels, or vagus nerve, phrenic nerve, trachea, esophagus, and so on. Vascular complication were in 6 cases, 46% from all complications, most of them due to extracranial, again, carotid artery ligation, while other complications were cranial nerve injury in 2 cases and combined injury in 2 cases. Speech defect was occurred in wide local excision of tongue glial cell tumor. Due to tumor local extension, Horner syndrome and quadriplegia were reported in 2 cases, diagnosed with neuroblastoma and malignant peripheral nerve sheath tumor, respectively. Mortality was reported in 6 cases out of 15 cases of malignant group as follows. Malignant paraganglioma, group 2 cases out of 4. Olfactory neuroblastoma group 2 cases out of 6, and the malignant peripheral nerve sheath tumor 2 cases out of 2. 100% mortality. So it is most aggressive tumor through all of these tumors. Then the overall survival according to Kaplan-Meier curves. This is the overall survival, and disease-free survival also for all of the group. Then intraoperative finding of some of picture I will show you. Intraoperative finding of vagal schwannoma. As you see, this is a vagus nerve. Here is the carotid. This is a common carotid, and here is the bifurcation of the carotid. Here is a vagus nerve, and this is a sternomastoid, and as you see, it is mass. Imagine that you approaching this mesh like a lymph node or lipoma or any other benign tumor, or like any part of the body, and then you discover it is arising from the vagus nerve itself. So that's why we conducted this type of research or this type of study, because this is a rare tumor. And another picture showing a carotid body tumor. Displaying the both carotid artery. Here is the carotids, and here is the carotid body tumor. And here try to mobilize the carotid vessels and control it because of potential bleeding while resection. And here is a picture of cervical neuroblastoma, which arises from the cervical ganglia of head and neck, cervical sympathetic chain. In child, this is a child picture. And this is an incision. It's called the trapdoor incision. Large incision called the trapdoor incision. So our conclusion, the patient's mean age was 34.7 years. Childhood neurogenic tumor, new tumors account for only 22.5% in this study, with female to male ratio was 1.5 to 1. Majority of head and neck neurogenic tumor are benign. The first line in management involves accurate preoperative evaluation and high index of suspicion. The presenting complaint of such patient depend on biological behavior of the tumor. Some of them present with slowly growing, painless, well circumscribed mobile lump, and mostly they are benign, and other presenting with rapidly growing swelling in addition to neurological symptoms, and mostly they are malignant of origin. Take home message. The principle of treatment involve complete surgical resection or zero resection, but the bulking surgical excision has a definite role also to control the disease. Resection and then reconstruction of the affected nerve should be attempted if serious affection happen. If you have bilateral, like if you have bilateral phrenic nerve affection on both sides, so you will it will end by diaphragmatic pulse for your patient. So you should consider nerve reconstruction. Malignant nerve sheath tumor are aggressive and are treated with radical surgical debulking followed by radiation. Unresectable or metastatic disease are best treated by chemotherapy. And this is the end. Thank you. And any questions, please?
No questions.
Posterior epistaxis management. I'm going to make this very, very concise. It's hardly a lot of slides, so I hope you guys enjoy. Introduction. One of the most common emergencies that we face as ENT surgeons is epistaxis. And the etiology of epistaxis, in majority of the cases, are unfortunately idiopathic. And posterior epistaxis, as we all know, is very common in old age due to systemic hypertension, etc. And when we come to management of posterior epistaxis, it can actually range from simple nasal packing to an extent of surgical intervention. Despite various measures that we take to control epistaxis, it's always been a nightmare if it's going to be an uncontrollable posterior epistaxis. I'm sure all of us would have experienced such case in our career till now. So the aim of the study is a retrospective analysis to see the surgical management of recurrent posterior epistaxis in a tertiary healthcare center. Objective of the study was to find out the etiology and the cause of posterior epistaxis. And further on, we wanted to see how many went for a surgical management and how many had a conservative management as well. Study design, it is a retrospective study. It was done in Department of ENT in a tertiary care center. We took data of 5 years from 2018 to 23, and the sample size, we were able to draw it on over 41 patients. And we made sure it is a single surgeon's surgery. All the patients who presented with posterior epistaxis were included, and all the age groups were included as well. We excluded the patients who presented with anterior epistaxis and who had underlying coagulopathy disorders. So methodology, all the 41 patients who presented to OPD with complaints of epistaxis were included, and various factors were taken into analysis, including the demographic details, hemodynamic stability of the patient at the time of presentation, what is the cause of the epistaxis, if they had further underlying comorbidities, and the duration of presenting symptom. Further, these patients were then managed either conservatively or surgically, depending on their course of how they progressed. And intractable epistaxis and their management were also taken into account. So coming to the statistical analysis, in our study, we found that we had categorized, if on gender distribution, they were 66% of them were male and 34% were female. And patients who were more than 60 years were 12 patients. Majority of them fell in the age group of 12 to 60 years. And 6 of them fell into the category of less than 12 years. So which means less than 12 years, there were 15% of the total population contributed to less than 12 years. 29% of the study population contributed to more than 60 years, whereas the major chunk fell between 12 to 60 years, which is 56%. And etiology, as we can see, trauma, there were around 19 patients, and secondary epistaxis, there were around 13 patients. Post-surgery, there were patients presenting with posterior epistaxis, which were 3. and idiopathic cause were around 6. Most of the patients presented with frank bleed, wherein 6 patient, which is accounting to 15% of the patient, presented with nasal pack from some other center, as in they had their first aid and their initial treatment elsewhere, and then they presented to our department. As a result, this is how we managed. 3 of them were managed conservatively with just positional variation, as we all are well aware of. Further, 18 of them had nasal packing with just basic roller gauze. And further, 3 of them had balloon tamponade. And 4 of them, and further, 4 of them had endoscopic sphenopalatine artery cauterization, and it was ligated in 11 patients, and 1 patient went for external carotid artery ligation, which is very, very rare these days. So this is an image showing ESPL ligation, endoscopic sphenopalatine artery ligation. And as a result of our study, postoperatively nasal packing was removed after 24 hours, and further no episodes of bleeding were noted. Coming to discussion with recent advances, as we all know, and with the boom of endoscopic use, surgical management of posterior epistaxis has had a major paradoxical shift from open neck approach to a more efficient and advanced endoscopic involvement and technique. With endoscopic involvement, we are able to use it for assisted cauterization and ligation of bleeding vessel in the field of ENT. In our study basically shows that endoscopic management of retractable epistaxis is much more efficient and less time consuming when compared to a conventional approach. Endoscopic approach is found to be, as a conclusion, endoscopic approach is found to be much more safer and compatible with our current practice. Sphenopalatine artery ligation was proven to be an effective measure in controlling intractable epistaxis in our study population and in our center. As a whole, when we felt that the study had good positive outcomes. And these are my references. Thank you.
Thank you so much, Dr. Aishwarya, for the presentation. So any question regarding her talk?
This case actually is not only a rare case, it's actually an extremely rare case. So as you see, this is the table of contents of my presentation, which include brief on history, physical examination. I will display some videos about the radiological study of this patient and the importance of MDT multidisciplinary team meeting in such cases. Then I will show you the main steps of the surgery done for this patient, post-op care, histopathology report, and literature review of the diagnosis of this case. So I have a 38-year-old male patient, medically free, who presented to the ENT clinic with history of left-sided rhinorrhea for several months. Actually, it was a clear secretion, increased while the patient was tilting head forward and downward, and it increased within the past 2 months. Also, the patient was complaining of mild headache. There was no history of trauma or any symptoms of increased intracranial pressure. And when the patient came to my clinic, actually, he didn't receive any treatment, either medically or surgically. Medical examination showed positive T-spot sign and nasal endoscopic examination in the clinic. showed left-sided sinonasal mass filling the left middle meatus and left watery secretion. All lab workups were done, and they were within normal limits. Beta 2 transferrin actually not done because it was not available. Sinus navigation CT scan was done in addition to MRI sinuses and brain, and we'll discuss it in videos in next slides. Cysternography was not done also because it was not available in our hospital. So as you see, this is a coronal cut CT sinuses. As you see, this is the opacity in the left anterior ethmoid sinus. As you see, it's extending into the left maxillary sinus. And as you see, when we are going backward, there is another opacity occupying the left sphenoid sinus with, as you see here, skull base defect. As you see, here is the skull base defect. And this is the sagittal. This is a sagittal view of CT sinus. As you see here now, the opacity in the left maxillary sinus and extending into the left anterior and posterior ethmoid. And there is another opacity separated in the sphenoid sinus posteriorly with the skull base defect and in the clivus. And this is an axial view. Also the same as you see here is there is opacity in the anterior and posterior ethmoid sinus. And there is another opacity in the sphenoid sinus, as you see. So as you see in the CT sinuses, we are dealing with two separate opacities and pathologies. And this is MRI, T2 MRI, showing hypointense and actually it's heterogeneous hypo and hyperintense in the left maxillary and anterior ethmoid. And as you see here, it's hyper enhanced fluid in the left sphenoid sinus. And this is the MRI again showing the mass in the, as you see in the left max and anterior and posterior ethmoid, and there is another hyper intense hyperintensity in the left sphenoid sinus, filling the whole left sphenoid sinus. And this is the axial. This is the axial, as you see, T2 MRI also, and as you see the left sphenoid sinus is filled with hyper intense fluid, which is most likely the CSF. And there is another pathology anteriorly, which is hypointense, occupying the left maxillary and anterior and posterior ethmoid sinus. This is another video also, axial cut, T2 MRI. And as you see, we are dealing with two separate pathologies. This is a sagittal T1 MRI showing anteriorly the hyperintense in T1 and hypointense in T1, the CCF in the sphenoid sinus posteriorly. And as you see, again, this is the sagittal T1 showing hyper iso-intense opacity and intensity in the anterior and posterior ethmoid, and another pathology in the sphenoid sinus, which is filled with this fluid in the left sphenoid sinus. Here, this is MRI of flare signal, which shows suppressed CSF in the left sphenoid sinus. As you see, this is axial T2 MRI with flare signal, which showed suppressed CSF in the left sphenoid sinus. This is T2 MRI with FISTA signal. As you see, here is the hypointense in T2 soft tissue in the left maxillary and anterior and posterior ethmoid sinus. And when we are going posteriorly, you can see now the hyper intensity in the left sphenoid sinuses, as you see that is filling the left sphenoid sinus completely. So this is a coronal T2 MRI with fist signal, showing the hypointensity mass in the left maxillary anterior and posterior ethmoid. And when we are going backward, you can see the left sphenoid sinus is fully filled with CSF, which showed high hyperintensity. And this is the axial, also MRI T2 with the fist signal. And you can see here the mass in the left anterior ethmoid and posterior ethmoid. And you can see posteriorly the hyperintensity and occupying the left sphenoid sinus. So you can see this is T2 MRI with fist signal, axial view. You can see the hypointensity hypointense mass in the left anterior and posterior ethmoid sinus, extending down to the maxillary sinus. And there is another hyperintensity of fluid occupying the whole left sphenoid sinus. So, as you know, in these cases with sinonasal pathology, with which extending into the intracranially, it's very important in this case to involve the neurosurgeon. We need their help in lumbar drain, and we'll discuss with them also the benefit of acetazolamide. For these cases, actually, this patient was admitted and lumbar drain was inserted, and also acetazolamide was given post-op. And also, it's very important in these cases to discuss with the radiologist the differential diagnosis of such cases and the extension actually of the disease and the mapping for the surgical approach of such cases. So we took a decision and we proceed to the patient to do endoscopic sinus surgery. We started the surgery by doing a left ancynectomy with middle meatal enterectomy. Then we did anterior and posterior ethmoidectomy. Then after that we explored there was a polypoidal mass occupying the anterior and posterior ethmoid extending to the left maxillary sinus. Biopsy was taken and sent for histopathology. Then we completely excised the mass. Then we took a rescue flap, and we took also an nasoseptal flap, and we stored it in the left maxillary sinus. Then we proceed to sphenoidectomy. We identified the meningocele actually intraoperatively coming from the clivus, occupying the left sphenoid sinus. I will show you in the picture in the next slides. So we did the reduction of that meningocele and we reconstruct the defect using a rescue flap. And using actually the nasoseptal flap in addition to the we use the nasoseptal flap in reconstructing this defect. So as you see, this is a picture of the meningocele coming from the clivus, and this is after reconstruction of the defect by rescue flap, and also we used Duragen, synthetic Duragen in reconstructing this defect. So post-op period, patient was hospitalized for 3 to 4 days on lumbar drain, and there was no complication during the post-operative period in the hospital, and patient discharged home in stable condition. And this is a CT scan, and this is a CT scan coronal view, which showed the sinus after excision of the mass and the reconstruction of the clival meningocele defect, as you see here. You see here the defect was repaired completely. So this is a CT scan of the patient 2 months post-op, which is showing complete excision of the mass, and either in the mass in the anterior or posterior ethmoid and maxillary sinus, and also the sphenoid and reduction of the clival meningocele with the reconstruction of the clival defect. And this is the sagittal view of the same patient 2 months post-op. And this is the sagittal view of CT sinuses of the patient 2 months post-op. As you see, complete excision of the mass and reconstruction of the clivus. So the pathology, I saw the patient 1 week after discharge, and the result of the histopathology of the ethmoid polypoidal mass came as sinonatal papilloma exophytic type, and it was negative for dysplasia and malignancy. So as you see, this is a case of this case is showing 2 different separate pathologies, which is clival meningocele causing ccephalorrhea, in addition to the sinonasal inverted papilloma involving the left anterior posterior ethmoid sinus and left maxillary sinus. Actually, I did a literature review of such combination. Actually, I didn't find any single case in the literature review. So if anybody has any case before, or I did I did a comprehensive literature review actually, and I didn't find any association between these two pathologies before in any database. I found these two articles, and one of them for Bedard Shaherjerdi and his colleagues in December 2012, who reported the coexisting of sinonasal inverted papilloma with angiofibroma, and another article for Ricardo Menendez and his colleagues in January 2020, who reported pituitary macroadenoma with sphenoid sinus inverted papilloma. And this is the two only articles which I found it in the literature review. But for my case, I didn't find any case reported before for such association between clival meningocele and inverted papilloma. Thank you.
So that was an excellent video presentation by Dr. Al-Johani.
American influence in this part of Mexico. And talking about research, we have much collaboration between Texas universities and Northern universities. And today I'm going to talk about a very interesting topic called pathogenesis and oral related factors in post-COVID-19 mucormycosis patients. This was a systematic review of case reports. First of all, I have to say that the pathogenesis and the factors related to COVID-19 involve much diseases than the virus itself. What I mean is that COVID-19, when it started the pandemic, it brought with itself certain diseases such as the black fungus. I don't know if you have heard about it. It was quite well known in Mexico because we had a few cases. And in this case, we, as dentists, because we are dentists, we are at the School of Dentistry, we started to see certain patients with certain conditions. And approximately 1 year or 2 years after the pandemic started in March 2020, we started to see this kind of diseases. In the palate, we started to see certain holes, quite medium or large, and we started to study that kind of diseases. And we saw this was a fungal infection related to a fungus called mucormycosis, and we started to associate it with certain conditions, immunosuppression, the use of corticosteroids, and diabetes, specifically diabetes type 2. And then we started to read in the literature what happened with those patients. And we conducted a systematic review to evaluate what was going on. And you may ask, well, this is an otorhinolaryngology symposium forum. We have to talk about that kind of conditions. But I think the intercollaboration between specialties, between all the medical staff, it's what enriches research and treatment to patients. And we started to see that this was growing, this kind of diseases. So we conducted the systematic review and we found really interesting things. And the aim of this study was to examine the pathogenic mechanism and oral related factors in post-COVID-19 mucormycosis patients from a dental perspective. And the rationale of conducting this research and being exposed in this forum is that, as you may know, this can affect not only the mouth. This kind of lesions can be spread to nasal conduct, affecting smell, affecting the breathing of people, and all the aerial via. So this is a rationale for this study. So we designed a systematic review of case report, then we registered on the Prospero site. We search on certain databases such as PubMed, Google Scholar, POAJ, NIH Library, Embase, EBSCO. And after all the screening of the manuscript, we retrieved 32 cases report. Beside of that, we had a heterogeneity evaluation, certainty of the evidence with great guidelines, and the risk of bias with the Cochrane methods. And then what we could see in all the literature published worldwide is that the average age of people with this condition was 53 years old. Furthermore, what really impressed us is that male were the most affected with this kind of diseases. After this, we were talking about that diabetes and certain comorbidities were associated, and we saw certain association, a weak association between hypertension and a little bit more strong between diabetes and mucormycosis. More than half of patients said they had pain, really strong pain, and maxillary bone exposure. This was the odontological thing that really impressed us, because these kind of patients were going to the dental consultation, but after a medical consultation. And when medical staff ask this person, why don't you go, why did you come here to the medical examination, to the dental examination, they said that doctors could not lend attention to this patient because the lesions were in mouth. Okay, and then we retrieved some diagnostics for these people. Most of all were with incisional biopsy, pathological analysis, and most of them were treated with amphotericin B. Almost 60% of all the patients that we retrieved in the literature, and the treatment was surgical. It means that the patients were removed from that part, from the bone, maxillary bone. In all the case report we retrieved, we only found that one case report was from a patient that passed away, that died. Okay, and then we go to the dental relevance, because most of the patients go to the dental consultations and because it's something in the mouth. But as dentists, we try to study what happens. And they go because they have tooth mobility. Some of their teeth are very mobile. So some of them were falling out, and they had certain dental procedures previous, such as root canal treatments, but only 6.25%. And then in here we can see a picture of a surgical debridement from a patient. And as you can see, this is a very large extension, because mucormycosis, this kind of fungus, expands and get larger every time. What really caught our attention is that mucormycosis grows very fast. So we have retrieved manuscript that declare that in 1 month, patients were disaffected. And in another 5 or 6 months. So what are the main implications between this kind of treatment is that a multidisciplinary work between medical staff, dentists, nursery, and all the medical staff could pay more attention between this and give a better attention to these patients. Is not only a dental thing, is not only a medical doctor staff. It involves everyone because, as you can see, are lesions in various parts of the face and the mouth. So the recommendations in here from the nursery staff are very appreciated from the dental perspective, medical perspective. And about this, we can conclude that there was a low association between the use of certain types of corticosteroids with this kind of fungus, and the dentists play a very, very important role in this. As I said, all the medical stuff, and obviously the early diagnosis. Okay, and this opened a big panorama for all because mouth not only comprises dental stuff, it involves everyone. So I think we can play a very, very significant role in this and to prevent further lesions in patients. So thank you so much for your time. It was a live presentation. Because I was the last one, so I didn't want you to stay here for longer time, but I am very open for questions or comments that you have. Thank you so much, everyone. I am opening my, yes.
Thank you so much, Dr.
Thank you so much,
for the
Dr.
presentation.
Thanks to you.
Yes, so any questions from the audience side?
My screen, okay. So just before getting it started, I'd like to present a field picture of the research where it was done. So this was the setup. Why we decided to study this research is there are underlying dietary health problems and dental caries as one of the reason for causing direct influence on children's health, and body mass index is the parameter to reveal the health status of children, one of the parameters. So hence the study was done. A research question is there any association between dental caries and body mass index among children? So basically our hypothesis was there is an association, and our results also say that there is. And moving on to methodology, it is an observational retrospective study where we actually filled in the WHO dental caries form and then took it from there to analyze the BMI as well as the dental caries in primary as well as permanent dentition. So if you guys are maybe aware of that, in children there are basically two types of dentition seen. One is the milk teeth, the primary, and the secondary. So we took the data for both the set of teeth, and our method of inclusion was students between 5 to 16 years, students of both gender. But the only thing I would say that here we did not include any children with any underlying medical condition, though there were students who were malnourished and having severe nutritional problems. That was the only thing we noticed. What did we assess? We assessed the WHO oral health assessment form, which I'll show in a moment. Height, weight, head circumference, and mid-arm circumference. Data analysis was descriptive and analytical statistics, and chi-square test was used, and significance was kept at the primary one, P, that is less than 0.005. This is the base annexure form, which is apart from the WHO form, the data that we collected. As you can see, this is just the basic information, and this is the oral assessment form. This is how it's looked when we we analyze the dental condition of each children. So this is for one child, there was this form which was filled, and there were about 500 subjects. So data analysis, I previously also mentioned, it was BMI, weight upon height square. We compared the gender and age specific Z score cutoff range, which the WHO guidelines. Sample classification was based on gender and age, and for the category purposes, we divided it into 4 categories: underweight, normal weight, overweight, and obese. Since it was in slightly rural area, there were not much subjects with overweight and obese. Many of them were underweight and normal weight. Again, dental caries was assessed in DMFT. This, if you can see my cursor, the small letter DMFT refers to the deciduous dentition, and the upper scale DMFT refers to the primary permanent dentition. This is the software which was used, SPSS version 24. Again, descriptive analytical statistics done, Pearson's chi-square test, and for table 2, we did multinomial logistic regression to calculate the odds ratio and the confidence interval, again keeping P less than 0.005. So the reason we use multinomial logistic regression was since our categories were 4, our outcome variable is generally categorized to 4 different categories: underweight, normal weight, overweight, and obese. Hence, we chose the multinomial logistic regression. This is a simple pie chart which we can see. Majority of them needed prompt treatment, including scaling. Basically, their dentition was bleeding or needed prompt treatment like caries filling, etc. Immediate urgent treatment was only required by about 5% of the population, and 20% needed routine or preventive treatment for that. Following, the results continued. Mean age was 11 to about 3, plus and minus 3 years. Again, the categories, as you can see, 80% were underweight. So that's a huge population which was underweight. So results really are falling under this category. Our main findings were younger children were more underweight than lower children. Underweight children showed a higher prevalence of dental caries in deciduous dentition. So the p-value is very significant here. And again, significant association between age and BMI and high caries rate in underweight children. Results continued. Again, underweight children, 20%. This results is interpreted for the multinomial logistic regression. So 20% higher odds of dental caries in permanent dentition, and 2.05 times higher odds of dental caries in deciduous dentition. For overweight children, 10% of lower odds of caries in permanent dentition, and 0.5 times lower odds of caries in deciduous dentition. And for genders, so this is for females, we saw a lot of subjects who were female. They had twice the chances of developing dental caries in permanent dentition, and 20% of them had lower odds of dental caries in deciduous dentition. So for permanent, they had twice the times, and 20% lower odds for dental caries in deciduous dentition compared to males. So the conclusion, risk factors, again, deciduous dentition being underweight is a risk factor, and for permanent dentition, in our results at least, female gender was risk factor. Again, this is my study group. Entire study group created the field research. So really thank you for this opportunity, and I may stop my screen. Thank you so much.
So thank you so much, Dr. Snehal, for the presentation. So any question?
Please let me know if there are any questions. Happy to answer. Thank you.
The title of our presentation is ABC functions and the
Principio RES-MA-DE-FON.
and the principle RES-MA-DE-FON. Can you hear us?
Yes.
Sí, nos escuchan. Si quiere, pedimos la siguiente diapositiva.
Sí.
Y seguimos preguntando. Okay. Next slide, please. Creo que ya se puso la siguiente diapositiva. Si
¿Pero de seguridad toda, verdad?
Sí nos escuchan. Pregunté y me comentaron. Así que voy a traer las diapositivas en el celular. Y usted, si quiere, puede seguir.
Can you see the slides?
We cannot, but we can make the presentation without seeing it.
Yeah, I guess Professor Ordon is facing a technical issue. We will wait a few more minutes.
Hi, can you hear us?
Yes.
Yes. Sorry, we had trouble again, but we are now ready to start. Can we
Okay, not
start?
an issue.
not an issue. Va, diga.
Esta es una introducción que yo quiero realizar entre los odontólogos y los otorrinolaringólogos.
This is an introduction I want to make between the otorhinolaryngologist and dentistry.
Todos sabemos que el doctor James Coslet en 1930, los años de 1930, diagnosticó a 11 casos que tenían alteraciones de la articulación.
We all know that Dr. James Coslet first described in the 1930s that a dental malocclusion with diagnosing 11 patients.
Esto nos abrió la puerta a nosotros los odontólogos para empezar a interesarnos en problemas de la articulación temporomandibular.
This is why we as dentists started to get into the improper alignment of the teeth when biting.
Desde esa fecha en adelante se ha propuesto este tipo de alteraciones del oído y la articulación temporomandibular como el síndrome de Coslet.
Since then, the issues that have been with the TMDs and also the hearing have been defined as the Coslet's syndrome.
De aquí en adelante, los odontólogos han tomado más interés en este tipo de alteraciones debido a este principio del Dr. Kosten.
Because of the principle of Kosten syndrome, odontologists have started now to pay more attention to these disorders.
Aunque ahorita por parte de los odontólogos ha habido algunos cambios, pero siempre ha sido la base lo que propuso en los años 30 el profesor Kosten.
Even though the odontologists have proposed a more specific qualities of this syndrome, the basis that Dr. Kosten settled back in the 1930s are still very important today. Now you can change the slide, please.
La definición que se propone actualmente de desórdenes temporomandibulares, o sea, lo que es el síndrome de Kosten.
Next slide, please. Espérame, no comieron las diapositivas. Thank you.
Sí, la definición que se utiliza actualmente acerca del síndrome de Kosten, propuesto ya por estudiosos en odontología acerca de este problema.
Now, going with the definition settled by the professionists of odontology nowadays is
sobre todo por las cuestiones básicas del dolor orofacial, que incluye cabeza, cuello y cara.
Is according specifically to the definition now in orofacial pain association. Okay, now, according to the definition of the American Orofacial Pain Association, a temporomandibular disorder, TMD, is a collective term that encompasses a series of clinical problems that affect the masticatory muscles and the temporomandibular joint and associated structures, among them the ear and its components. Next slide, please. Next slide, please.
La prevalencia de la Organización Mundial de la Salud acerca de ese tipo de trastornos temporomandibulares o síndrome de Kosten.
The prevalence with the ¿quién dijo que era la organización?
La Organización Mundial de la Salud.
World Health Organization is due to the wide presence of risk factors, estimate that the TMD or Kosten syndrome.
Este tipo de problemas, según la Organización Mundial de la Salud, es más prevalente en las mujeres y en sexo y en edades más pequeñas, cosa que antes era de edad más avanzada.
According to the World Health Organization, the prevalence is widely more present in women and small kids rather than adults, as it was thought as before.
Dentro de los factores de riesgo que prevalecen a la aparición de este tipo de trastornos temporomandibulares,
amongst the symptoms that we can identify for the temporomandibular or Kosten syndrome disease,
encontramos, por ejemplo, la ansiedad, el estrés,
we can find anxiety and stress,
el bruxismo,
bruxism,
trastornos directos o indirectos a la articulación temporomandibular,
different indentations in the temporomandibular area.
El proceso de masticación que es importante desde el nacimiento.
Process of chewing that is very important since birth.
Por supuesto, la mala oclusión dental.
The wrong mouth occlusion.
Y también problemas de el oído, de la parte que contacta a lo que es la articulación. Sabemos muy bien.
And of course the ear too, as we know that there's an articulation there.
Que estas dos estructuras, articulación temporomandibular y el oído, son vecinos muy próximos.
¿Puedes repetirlo, por favor?
Son estas dos estructuras, la articulación temporomandibular y el vecino que es el oído, son estructuras muy fáciles de alterarse.
That the structure of the hearing and also the temporomandibular structure can be altered very easily. Next slide, please.
para comprender algunas relaciones, la relación que hay entre otorrinolaringólogos y el dentista.
To understand the relationship between otorhinolaryngology and dentistry,
debemos de revisar algunas estructuras básicas que incluye estas dos áreas médicas.
we must revise the anatomy of these two structures and their intimate relationship with each other.
Estas estructuras estando tan cercas,
because that these structures are very close to one another,
yo propongo en forma personal que sea nombrada una articulación ototemporomandibular.
I propose that this combination of structures is named.
Debido a la cercanía de estas dos
¿Puedes
estructuras,
repetir la estructura? ¿Cómo se llama?
la estructura temporomandibular.
The temporomandibular structure, that is the name I propose.
Es obvio, nosotros los odontólogos y los otorrinolaringólogos sabemos muy bien de la facilidad con que estas estructuras pueden dañarse.
We both, as otorhinolaryngologists and dentists, know how easily these structures can be damaged.
De manera que mi intervención en esta conferencia es enfatizar la perfecta relación que debe haber entre estas dos áreas de la salud.
And so I want to emphasize that it is necessary to have a very close interaction between dentists and otorhinolaryngologists.
Tradicionalmente se ha visto al odontólogo como un restaurador de la dentición.
Very commonly is known the dentist as one that can repair the teeth and all its alignment.
Pero yo en mis clases que doy en la universidad siempre enfatizo a los alumnos que debe de ser un diagnóstico mutuo entre oído y articulación.
But since I am a teacher at university, I always tell my students that it's very important that the sessions involve not only the teeth, but also the regions of the hearing.
Sabemos nosotros que conocer la anatomía y la funcionalidad correcta de una estructura es importante para determinar la desviación.
We know that it's very important that knowing the anatomy and the structures perfectly is very important to determine the patient's condition. Next slide, please.
Algunos síntomas y signos característicos de este tipo de alteración de la articulación temporomandibular o síndrome de Coslet.
Some of the symptoms that are important to identify the Coslet syndrome and the temporomandibular joint tension disorder are.
Son los que afectan directamente a estas estructuras o afuera de estas estructuras.
Are the ones that we know that affect directly these both structures.
De manera que podemos encontrar problemas externos o musculares e internos de la propia estructura.
That way we can find if the problem is internal, external, or musculatory.
Estos signos y síntomas son variables.
These signs and symptoms can vary.
Pero es importante, como repito, conocer la anatomía para conocer también lo que se altera de la función.
And that's why I believe it's very important to know the structure and the anatomy of each part, as anything can tell us exactly where the problem is.
Sabemos que estas dos las lesiones a estas dos estructuras forman parte de lo que se conoce como dolor orofacial.
We know that the pain that is caused in this area, it's called orofacial injuries. Next slide, please.
En esta ocasión, ante ustedes, con el debido respeto, propongo un término para conocer las alteraciones de estas dos estructuras anatómicas.
So I propose this method so we can identify more clearly what are the issues that should be revised in order to identify if this problem is being caused.
Es un término que he denominado RES-MA-DE-FON.
This term I've named RES-MA-DE-FON.
Que incluye básicamente las 4 estructuras o 4 matrices funcionales importantes para el desarrollo facial.
which include the 4 matrices of basic functional interest for the dentist and the otorhinolaryngologist.
Como ustedes observarán en la diapositiva, res es respirar, masticar.
As you can see in the slide, res is for respirar, which means breathing, ma for masticar in Spanish and chewing in English,
Deglutir y fon hablar.
de for deglutir in Spanish and swallowing in English, and fon hablar, which is speaking.
Si estas matrices funcionales se desarrollan correctamente,
If these 4 matrices develop correctly,
el sistema estomatognático y auditivo funcionarán correctamente.
the system stomatomatic and auditive and hearing will work perfectly.
Por lo tanto, debemos suponer
That is why we must identify or suppose
que las alteraciones a estos matrices funcionales
that any alteration in these 4 matrices
traerá problemas en estructura y función.
will bring problems in structure and function.
Este principio RES-MA-DE-FON de mi autoría,
This principle of RES-MA-DE-FON that I made,
quiero proponerlo para los compañeros otorrinolaringólogos y odontólogos
I want to propose for both otorhinolaryngologists and odontologists
para que sea de fácil comunicación la simple palabra de decir RES-MA-DE-FON
in a way that we can make RES-MA-DE-FON a common term.
nos estaría indicando las matrices funcionales de las que se está tratando.
So we can identify the 4 matrices that we are talking about. Next slide, please.
En esta imagen que observan,
In this image that you can see in this slide,
están los grupos funcionales que son de mi autoría,
are the functional groups that I made myself,
donde está indicando de que una alteración de estas 4 matrices funcionales
where we can see clearly that any alteration of one of these 4 matrices
si se llegan a alterar, serían obstáculos para un crecimiento y desarrollo
would become an obstacle for development and growing.
Los 27 grupos funcionales que forman este código ABC
The 27 functional groups that made this ABC code
son básicos para comprender
are basics to comprehend
el fenotipo de estas estructuras que producirían estas estructuras.
the phenotype that these structures would create.
Brevemente, indico de que un niño que nace con el genoma aportado por sus padres
You can see here that the genome that I propose, that I explained, can create this type of mutations where the parents gave the phenotype to the children.
Trae toda la carga genética, o sea, la información.
And it has all the genetic information.
Y esta es modificada por el medio ambiente o factores epigenéticos.
Which can be modified by the ambience and development.
Que se pueden manifestar en el principio RES-MA-DE-FON.
And could manifest in the principle RES-MA-DE-FON. Next slide, please.
En esta tabla
in this table, we can see
se observan los 27 grupos funcionales con más precisión.
The 27 functional groups with more precision.
Y el principio que respalda esta teoría de los grupos funcionales
and the backbone, meaning that's backbone of these functional areas.
Dice lo siguiente.
Says the next thing.
Si una estructura
if a structure
cruza un umbral
crosses the threshold
y su contraparte
and its counterpart
no lo hace en la misma dirección y proporción,
does not do the same in the same direction and proportion,
habrá problemas en su relación de forma y función.
There will be problems in the relationship of form and function.
Y por lo tanto, desarmonía craneofacial.
And therefore, craniofacial disharmony.
Este concepto de los grupos funcionales,
this concept of functional groups,
lo propuse en el 2004.
I proposed it in 2004.
Y está publicado en la revista de la Asociación Dental Mexicana.
And it has been published in the magazine dentist, Mexican dentists.
Este principio, tanto RES-MA-DE-FON como los grupos funcionales,
This principle, RES-MA-DE-FON and also the functional groups,
lo ocupo en mis clases personales
I use it in my personal classes
de oclusión,
of occlusion,
de dolor orofacial
of orofacial pain,
y alteraciones del síndrome de Coslet.
and Coslet syndrome alterations.
Como conclusión,
As a final thought, next slide, please.
como conclusión, mi participación en este congreso
My participation in this Congress
se basa específicamente
is based specifically
en que se tome en cuenta la correcta relación que debe de haber entre estos dos profesionales, el otorrinolaringólogo y el odontólogo.
is embracing this strong relationship between the otorhinolaryngologists and the dentistry.
Todo esto por el bien del paciente.
All of this for the good of the patient.
Termino mi presentación con esta frase.
I want to finish my presentation with this phrase.
Decía en los años 30 del siglo pasado, el doctor William Coslet,
William Coslet said in the 30s of last century
que para un médico lo más interesante e importante
that for a doctor, the most interesting and important thing is
es el diagnóstico.
the diagnosis.
Él proponía que un diagnóstico acertado
He proposed that an assertive diagnosis
llevaba de recorrido más del 80% del tratamiento.
was already 80% of the treatment.
Una frase que me parece interesante para tomar en cuenta lo importante que es conocer una estructura
A phrase that I consider is very important to acknowledge the importance of a structure
y saber cómo se está desviando de la norma.
and knowing how it is getting away from what is the normative.
Por mi parte, es todo en mi presentación. Espero haber contribuido en algo en este congreso acerca de la aportación de los grupos funcionales y el principio RES-MA-DE-FON.
This will be all of my participation. I hope that I help a little bit with my research and also like bringing specifically the functional groups and the RES-MA-DE-FON concept.
En esta imagen, por último,
In this last image,
aquí estoy en mi laboratorio personal de investigación.
I'm in my personal laboratory for investigation.
Y solo me queda restar. Muchas gracias por su atención. Y si hay alguna pregunta.
And I just want to say thank you for your attention. And if you have any questions,
Con mucho gusto trataré de contestarla.
I'll answer them gladly.
Thank you.
Thank you.
A ver, vamos a ver qué dice.
Thank you so much, Professor Orden and a translator. So any questions regarding the presentation?